हेलो जी बोले संदीप बोले
अभी
नहीं,
रियल लाइफ सर
शाम को
स्वप्निल सर
Yes.
कल शाम को 4 बजे.
So, very good morning to all the viewers of Momentum 2021. As we all know that the Indian Orthopaedic Association annual conference is going to be held in Mumbai in the last quarter of 2021. And this is a program to not only showcase the various associations which would be participating, but also to increase the academic interest of all you viewers and inviting you to this mega event which is to happen in Mumbai next year. Today, the Maharashtra Orthopaedic Association and the Bombay Orthopaedic Society are proud to have yet another dynamic association along with us. Today, we visit the land of the Maharanas, the brave warriors, the Rajputs. Today, we have the Rajasthan Orthopaedic Association as our guest association with the president and the secretary, that is Dr. Rajesh Goel and Dr. Rahul Katta with us, and 4 dynamic and experienced faculty along with us. So without much ado, may I now request our Honorable President of the Maharashtra Orthopaedic Association, Dr. Ajit Shinde, to address us. Dr. Ajit Shinde is also the organizing chairman of IOACON 2021. He would be addressing us, followed by Dr. S S Mohanty, who is the president of the Bombay Orthopaedic Society and the co-organizing chairman of IOACON 2021. And this would be followed by Dr. Parag Sancheti, who is the conference director of IOACON Mumbai, and Dr. Chaddha, the organizing secretary of IOACON 2021. So I now hand over the proceedings to Dr. Ajit Shinde. Over to you, sir.
Good morning, everyone. I am Dr. Ajit Shinde, Chairman of IOACON Mumbai Organizing Committee and President of Maharashtra Orthopaedic Association. Welcome you all in this webinar series. Before I wish you and your loved ones safe life in this crisis, with India crossing 50 lakh cases, the situation is worsening day by day. So I urge all of you to take utmost precaution while treating your patient. So talking about this Momentum series, it has been a great learning experience for all of us. I would like to applaud for these extraordinary efforts from the young team, Dr. Swapnil, Keny, Dr. Pradip Nemade, Dr. Sandeep Biraris, and Dr. Dheeraj Sonone. All of them have worked hard to make each episode interesting and full of academic discussion. Today, again, we are back with interesting topic, complicated, neglected intra-articular fractures, and we have brilliant panel to discuss with critical problem. We have one more beautiful state, Rajasthan, with us, and I thank President Rajesh Goel and Secretary Dr. Rahul Katta for being enthusiastic participation. We have my mentor, my teacher, Dr. G S Kulkarni sir from Miraz, and eminent surgeon, Dr. Rahul Katta from Rajasthan as a moderators. Our young and dynamic surgeon, Dr. Pradip Nemade from Mumbai, is a convener for today's webinar. From Rajasthan, we are having Dr. Rajeev Bhargava, Dr. Jayant Sen, Dr. Kuldeep Nathawat, Dr. Sumit Banerjee, and from Maharashtra, we have Dr. G S Kulkarni, Dr. Anta, Dr. Pankaj Ahir, and Dr. Ajit Fadnis to present their interested cases. My best wishes for everyone. Jai Hind, Jai Maharashtra. I hand over the proceeding to Dr. Mohanty. Mohanty, please.
Thank you, sir. Very good morning to you all, and welcome to this webinar on complex intra-articular fractures. And I extend my greetings from Mumbai and Bombay Orthopaedic Society. Dear friends, as we know, Rajasthan Orthopaedic Surgeons Association, commonly known as ROSA, is very active in the academic field. Recently, we had a, in collaboration, we conducted a webinar on the digital orthopod, focusing on the digital activities of orthopedic surgeons. And I thank Dr. Rajesh Goel and Dr. Rahul Katta, being the leaders of Rajasthan Orthopedic Surgeons Associations, and to pursue this academic activity. And as you know, also in the meantime, during COVID times, also they conducted the midterm, state conference, and it was very successful, a digital conference. And also in 2015, when IOACON was organized in Jaipur, they also conducted their state conference about 3 months after. So extremely vibrant and academic organization. So we'll have a great academic feast today. And as we know that the corona is spreading its tentacles all over the country, let's have ROSA along with us. We spread our tentacles of academics all over the country through IOCON 2021. I thank you and wish a great success for this webinar. Thank you. Over to Dr. Parag Sancheti, the conference director of IOCON 2020.
Thank you very much, Dr. Mohanty, respected and distinguished guests today on the Zoom webinar, our President of MOA, Dr. Ajit Shinde, our esteemed guests for today, the President of ROSA, Dr. Rajesh, and the Secretary, Dr. Katta, and all members of ROSA, and my mentor, Dr. G S Kulkarni. We welcome you for this very good webinar. We have been organizing these webinars in the last 6 months in this lockdown, and this momentum has really given a big momentum for the IOACON 2021. Things have changed a lot in the last 6 months, and we have to accept the change and move on. I think these webinars is a good idea, and this momentum is also helping us to keep the momentum towards 2021, and the probable date is going to be the last quarter of 2021 for the IOA meeting, which we held in Mumbai. Dr. Ram, our vibrant secretary, will give you more information about the IOACON 2021. But all I want to say is that the preparations are going on. Please send in your scientific papers. Please register. I'm sure by then we will be over this pandemic, and definitely we will be ready to host this meeting. I want to thank all the organizers for this, especially Dr. Swapnil and Dr. Keny, who worked hard to bring this momentum together. The Secretary of MOA, Dr. From Pune, Dr. Karne, and also want to thank everybody in the Bombay Orthopedic Society on MOA for having all this together, and especially the convener for today, Dr. Nemade. With this, I just want to end by saying that, there's a very famous quote by Nelson Mandela, and I always like it. So it's very apt for this pandemic. I would like to say that, on what Dr. Mandela used to say, that you never lose, you either win or you learn. So I think this pandemic has taught us a lot of things, and we will definitely learn from it, and these lessons will go a long way. With this, I welcome everybody for this webinar, and over to our secretary, organizing secretary of IOACON, Dr. Ram Chaddha, for his address. Thank you, everybody, and have an enjoyable webinar today.
Good morning, everybody. Thank you very much, all esteemed seniors participating. President of the MOA and Organizing Chairman, Dr. Ajit Shinde, Co-Organizing Chairman, Dr. Mohanty, Conference Director, Dr. Parag Sancheti, Dr. G S Kulkarni, who is like a father figure, mentor, role model to all of us. Esteemed guests from Rajasthan, thank you so much for participating in Momentum. We are moving forward. We must realize that today, India has reached position 2 in the world, soon to eclipse United States of America. The state of Maharashtra, which is hosting this event today, is leading as far as cases are concerned in our country. And if you look at the total number of cases in Maharashtra itself, we are more than the 4th country, which is Russia. And the active cases in Mumbai, single city, are more than the active cases in the whole of Russia. And with due respects, Pune is even more active than Mumbai. So we are in a stage where, in response to any stress, we have gone through having frozen to a stage where we have indulged in a flight, running away from it, and now we are fighting it. But in this fight, we have realized that rather than fighting each other, we should tend and befriend each other. We should try cooperation, collaboration, and work together. I'm most grateful to all the states who have participated in Momentum, and especially to the Rajasthan Orthopaedic Society, the ROSA, which has come in today and will collaborate with us, will hold hands with us as we move forward, as we all believe that we are not in the same ship, but we are in the same storm. Let us move ahead, fight this together, and I'm sure, as Parag mentioned, we'll not only learn, but we'll overcome this crisis and turn this adversity into a big advantage for all of us. So, dear friends, have a very, very academic collaboration with each other, and let's move ahead. Over to the organizers, the conveners, and the moderators. Please be there for IOACON 2021, Mumbai, last quarter 2021, and we'll push you harder with academics till then. Thank you so much, and be there.
Thank you for those inspiring words, Ram sir. Your inspiration has been the momentum for us to take this conference into the Summit of Excellence. May I now invite our respected moderators, Professor Dr. G S Kulkarni sir and Dr. Rahul Katta sir, to kindly conduct the proceedings of this meeting. Over to you, sir.
Okay. Shall I invite the Rajasthan who is going to present the first case? Shall we start with the first case?
Yes.
Yeah, Rajeev Bhargava, Dr. Rajeev Bhargava, sir.
Yeah.
You can start sharing your screen and present your case.
Well, good morning, everybody. The stalwarts of Maharashtra Orthopaedic Association, my own colleagues. It's a great beginning this morning. Well, I start the ball rolling. I present a history of a patient who is 25-year-old, sustained roadside accident and injury to the left hip. The deformity suggests he had posterior dislocation of left hip. The CT scan shows Pipkin's fracture type 1 with posterior dislocation hip. There is no distal neurovascular deficit. All labs are normal. So, it's not moving.
Your voice is not heard.
Just Rajeev sir, just click on the slide 2 times. Yeah, just put your cursor and just click. Yeah.
So there's the CT of the patient. As you can see, there is a piece of head of the femur inside, and there is a posterior dislocation. This is the CT of the head of the femur. As you can see, there is type 1, probably bordering type 2 Pipkin's fractures. And the other views showing dislocation of hip. Now, moderators, would you like to have some discussion?
Yeah, we'll start the discussion. The first discussion would be whether you would reduce the fracture or reduce the hip first, or whether you would do the CT scan first. What are your views? Anybody? Why should we do first reduction, or why should we do first CT? I think CT has been done first.
Actually, patient came from outside with all these investigations.
Oh, I see. I see. See, now if the patient comes to you without CT, it is better to reduce the fracture first and then go on for CT. CT will give you all the information, whether you reduce it or whether you unreduce it. It will give you all the information. If you separate the bones, you will get it. So it is better to reduce first and then do the CT. That is what the controversy is. Many people say that no, we'll do immediately as it is available. If it is available immediately, one can do CT in the same. As soon as the patient comes, the CT department is ready to accept him immediately. You can do CT first and then you can do again. But if there is, you have to wait for the CT, and if you have to send it to somewhere else, not in your institute, then it is better to reduce and then good.
But it's not possible to reduce the dislocation since there is a piece of head inside.
Yeah, even then, you know, why it is reduced first, because you are in the sciatic nerve may be damaged, and once the sciatic nerve gets damaged, then it is difficult to treat it. That is the reason why the CT is done for. I mean,
actually, it was attempted somewhere else, but he couldn't reduce it.
Couldn't reduce it. Okay, okay, that's okay. So how?
I think
yeah.
I think what I quite agree with Kulkarni sir here. I think the point we are trying to make is that the CT scan should not hold up your attempt at reduction. If you have it right there, do it, but do not keep him unreduced just for the sake of a CT scan. I think that is a crucial point.
Because he is going to move here and there and sit up and this, that. In that, he might damage the sciatic nerve. Though rare, but it can happen. And it once happens, it's nothing, you know, it is very difficult to cure unless it gets itself cured due to just a stretching. Okay, let us go ahead. Whether to reduce it and whether to leave it because it is not in the weight bearing area. That is another question. Whether to just reduce it and leave it. And there is also fracture of the acetabulum, I think.
There is no fracture of the acetabulum.
There is no fracture of the acetabulum. There is some piece is seen here. Some piece is seen here.
Yeah, but that was not there.
That was not there. Very good.
Looks like a wall fractured.
Yeah, there was a fragment of the wall. If you go back, Dr. Rajeev.
I think it looked like if you see all this.
It's actually the piece of the head which is probably visible. You can see.
I see. Yes. Parag, what would you do?
So my plan would be to reduce this and then do a CT scan. That's generally, but if CT scan is available, it's good to do. But I would reduce it and then do a CT scan. So there are, if that inferior fragment falls into place and the alignment is good, then I will accept it, treat the patient conservatively. And then the superior piece, we have to see whether it is causing impingement. If it is causing impingement and coming in the weight bearing area, then it has to be opened and excised. And then at the same time, try and fix the infrafoveal fragment. But my post-op CT scan, depending on the morphology of the head fracture, what reduction is there, that will dictate whether I need to open it or conserve it. That would be my plan ahead.
So you wouldn't fix it?
I will fix it depending on the post-CT scan. I will not necessarily fix it. It's a very small piece. It will be very difficult to fix it. If at all, then I'll have to excise the proximal piece, and the infrafoveal piece I will fix.
Do you think it's a small piece? It appears to be 1/3.
No, there are two pieces, sir. The infrafoveal part, that's what I'm saying, we'll have to fix if we open up. The superior part is just a thin flake of cartilage. It will be difficult to fix it. That's what my thought process is.
Dr. Parag has told it was unreducible. So if it cannot be reduced, then how will you
then
proceed?
We have to do open reduction. Then when we do an open reduction, then the superior, the small flake of bone will be excised, and the inferior part is, as sir said, it's nearly 2/5 of the part that will have to be fixed.
I think the problem here is the superior piece that you see here. That may cause trouble. The inferior screw, it is not in the weight bearing area, but that superior screw may get incarcerated in the joint. And if it gets incarcerated in the joint, it might trouble, it might cause damage to the articular cartilage and may have to be removed.
Right, exactly.
Either you remove it by arthroscopy, if there is availability of arthroscopy, or open reduction. But if this piece would not have been there, the superior piece, then this piece is not important. This is innocent one because it is not in the weight bearing area. So in this case, I feel that one should remove the piece that is here. And then if you open it, then you better to fix this also. If you open it, if you don't open it, but as you said, if this piece gets fixed here and it is not doing any harm, then you may do non-operatively. So reduce and see. Yes, any other opinion? Mohanty?
I would fix it because, it is dislocated. So definitely it requires as early as possible, we need to fix it. And during that time, one has to check for the vascularity. If, vascularity is lost during the primary injury, then we can't help it. But at least try to keep the vascularity of the head as far as possible. Infrafoveal part can be fixed with the forward screw or something like that. That as Parag told that, that small flake of fragment, if it is not making the hip unstable, then it is better we can excise it to prevent a ectopic ossification. And it will come in the way of the mobilization also.
Okay. What approach would you take? Posterior approach or anterior approach?
You're asking me, sir?
Anybody?
No.
Yeah.
I'll
Can you?
whatever. So can anybody tell what approach? Anterior, posterior, or any other? These are the challenges which I felt. How to remove that piece of head from the acetabulum, because that will prevent all kind of reduction by close method or any other method. And
since it is posteriorly dislocated, posterior approach would be better.
Yeah, posterior dislocation would be better because the capsule is already damaged there.
Yeah.
And if you go anteriorly, you will damage the anterior capsule also. So it is better to go posteriorly as it is a posterior dislocation and reduce it. If that piece can be fixed, you can fix it. Otherwise, it can be removed. But the other fix needs to be fixed.
any other comment?
Yeah.
Any other?
I think since, as everybody has said, this was a posterior dislocation, so it is probably a better idea to go in posteriorly. And since it was not reducing as well flows, so if it had reduced flows, then I think your approach would actually be depending on where your fragment actually sits. That fragment. If it is a lot more anteriorly, then you are probably better off going from the anterior and fixing it. And if the fragment has a major bulk slightly more posteriorly, then it is better to go and fix it posteriorly. Otherwise, you will be struggling a lot to get your screws and wires in. So in this case, since it's not reduced and posterior, so I guess posterior, because it's dead inferior in this. That is my perception, that this would probably be just dead inferior in this case.
Yeah. Is anybody for Gans procedure? Flip operation? Gans
not
approach?
For this, not necessarily for this one, I suppose. But maybe.
Yeah, that is, if there is an anterior piece, large anterior piece, that flip operation would be a better approach. Otherwise, this is a posterior dislocation. The pieces can be taken out from the acetabulum and fix it with the posteriorly. So posterior, in this case, I would prefer a posterior approach. Anybody else has any opinion about approach?
I have a question actually.
Yeah.
does anyone use the direct anterior? It is a very fashionable approach kind of, but does anyone use it? I have never used it, but the respected senior faculties, have they got any experience with the direct anterior approach in these cases?
No, I have not done. Either I would do a Smith Peterson or go posteriorly.
Yeah,
that is
we
my.
don't have experience of a direct anterior approach, but it it requires little experience and technique wise and requires special instruments. Some of people they do with a special table also. So sometimes table, special table or special instruments. At least you should have to do a direct anterior approach. But as of now, it is more of a new approach. We don't know what the future will tell, but no distinct advantage. They tell early mobilization, early internervous plane, all these things have been described. But probably as time goes on, we'll know more about this anterior approach. How is it doing? But it's a new baby in the armamentarium.
Yeah, accurate. Okay, that how would you fix it? That is another question. Next is whether you would use a Herbert type screw or you would use a sunken approach. They use a screw with a head sunk in the cartilage.
Herbert screw is the preferred method.
Simpler method.
And simpler method. Herbert screw is the best method. Even if the fragment is little small, then also Herbert screw will have a good hold in the fracture fragment.
Would you fix the small fragment or only the large fragment?
So that small fragment, I'm not sure from where it comes. If it is coming from the margin of the acetabulum,
yeah.
After fixing the head fragment, I would assess the stability. If the head is stable enough, then I would not fix that small fragment. Rather, I'll excise it. But if the head is not stable enough, then I'll try to fix with some K-wires and put a buttress plate over it.
Agreed. But if it is from the acetabular rim, would you leave it or would you fix that to the acetabular rim?
That's what, sir, I told. If it is acetabular rim, after reducing the hip, you have to check for the stability. The hip is unstable, then we need to fix it.
It is bound to be unstable, no? Because it is the capsule, everything is gone. It is dislocated posterior.
I'll have to put fix it with a buttress plate with a couple of interfrag screws.
Yeah.
2 interfrag screws with a buttress plate.
Yeah, it is better to fix, I think, the acetabular. If it is from the acetabular rim, it is better to push.
Assis, your opinion, Assis?
I just lost connection in between. So that piece, is it from the acetabulum or is it from the head, Dr. Rajeev?
Yeah, that is very difficult to say from.
It's from the head.
Okay, if it's from the head, then no, but if it's from the rim, then definitely, then we should.
Yeah, that's
sir, right. Assis wants to speak something, sir.
So I thought that the piece was from the wall or the rim. If it's from the rim, then we can use the spring plates and do like a lateral repair to put it back, because then that would give a sort of a check rein to any future dislocation.
It will add to the stability of the hip.
Stability, yeah.
Certainly. So go ahead then. Next, what you did.
So the problem was that what I thought it will be difficult to approach this piece from the posterior approach without further devascularizing the head, and removal of the head will be a challenge because the neck and the unreduced portion of the head and neck will be blocking the view. That's one challenge and difficult to fix the fracture from posterior side. So I took this Gans approach, which sir already alluded that in this approach for my juniors, this is a very good approach if you want to see hip both anteriorly and posteriorly.
Yeah.
For my junior colleagues, I would just say this is done in lateral decubitus position. We take Cocker-Langenbeck approach and flip a piece of trochanter which attached gluteus medius and vastus lateralis. It's about 1.5 centimeter. it's flipped, and then capsulotomy is done in Z-shaped way, which is shown this way. So now we can take out the piece from here as we see the acetabulum, reduce the hip, re-dislocate the head anteriorly now. Once you dislocate the hip anteriorly, the fracture is right in front of you. And you can fix it with Herbert screws and check the stability. This is what I did. So I re-dislocated the head anteriorly. The fracture was right in front. I fixed that. That was a piece from head only. So as you can see, I used 3 Herbert screws. So I got good anatomical reduction, fixed the trochanteric osteotomy, and immobilized the patient for 3 weeks in abduction external rotation. Then I started mobilizing the patient. That was.
What are these 3 screws in the head?
These are headless Herbert screws.
Yeah, but how you fixed both the fragments, or you fixed
yes,
one?
I fixed both the fragments.
You fixed both the fragments.
Yes.
The superior fragment was also very large.
Was also of sufficient. It was sufficient dimension.
Yeah.
It was quite a bit of piece here.
Acha, so good. Yeah, excellent.
So that's the healed fracture, and everything is stable 3 months. But we have to keep a watch on vascularity after many months.
Yeah, that may take long time also. You have to watch for him 1 year, 2 years, sometimes 3 years also. That's true. Here, full recovered function is okay.
Yes, he's recovered very good functions. Is about 6-8 months now. Till the time there is no pain, but I have to keep a watch.
Okay. You have got. Yeah, very good. Any questions?
Dr. Pankaj has question.
Yeah. May I?
Yeah. So I do not remember the last time I fixed a femoral head more than 15 years ago, but I just have a small comment to make about the choice of screw that we use for fixing these intra-articular fractures. Since we in hand and wrist surgery we use these screws quite often. Herbert screw design is good when there are 2 large chunks of bone and there is enough bone for us to drive the threaded head into the bone. Where we are dealing with slightly thinner flakes, say 5 millimeter, 6 millimeter, or 7-8 millimeter thick flake, then those screw designs which do not depend on differential pitch for compression is a better design, because you have complete control over the amount of compression that you achieve even before the threads start engaging. So the headless compression screw design, if I am allowed to take names of the companies, then the Depew HCS design is far better than a Herbert screw design. So that was a small comment that I wanted to make.
Yeah. Good.
Thank you, Dr. Pankaj. Any other critical comments on this case, or some difference of opinion?
I think this is a good approach also. Many people do Gans procedure for having you. Then you will not have any problem with the taking out the piece from the acetabulum. Either you can go anteriorly, you can go posteriorly. That's a very good approach also. If you find it difficult, preoperatively you suspect that there may be some difficulty, then Gans approach is better.
Thank you, Dr. Rajeev, for a nice piece. So, will you unshare your screen?
Yeah.
Now, I would like to invite our next presenter, Dr. Jayant Sen, to present his case.
Everyone. Can I start sharing my screen?
Sure.
Yeah.
Please.
Starts.
Is it there?
Yeah.
Yeah, good morning, everyone. So, excellent case, Dr. Rajeev Bhargava. And what I'm going to present is something very routine and basic, which all of us have been doing. But just to bring out a few facts into what is the current thought processes in the management of the intra-articular fracture of the distal humerus. So I'll just begin with the case and then we can take it from there. The case is basically just to stimulate the discussion and lead us from there. So a 29-year-old male bank officer fell from a motorcycle and he's a dominant right hand. And this is the kind of injury that he landed up with us. So these were his x-rays. And I guess everybody would look forward to getting a CT scan. So I'll move on to the CT scans straight away. So I'll just hang around with the CT scans so that you can all take a look quickly. So I guess after taking a look at all the CT scans, we will agree that this is a type C3 fracture.
Yeah.
And so I think the important point here is that the intra-articular fragments need to be managed perfectly. There is no step. So in this case, we did a olecranon osteotomy, exposed the distal humerus, and we did our temporary fixations with K wires, got our stability, and this is where we ended up at the end of the surgery. I'll just run through the case because I think the discussion should follow the case. There is nothing very special in the case. We did a fixation of the intra-articular fragment with screws and then supported it with a 90-90 plate. And this is is about 2 months after the surgery. And I'll just share a video. Let me go back, please. And this is a recent video.
The video showing function, you mean?
Yes, sir. The video is to the right side. So he's got about 10 degrees function deformity. For the flexibility.
The video is not visible, Dr. Jayant. If you could just tell us the range of movements actually.
Okay.
Okay, I'm sorry.
Okay, we accept it.
It's showing on my screen. So, okay. Can you see it now?
No.
No, Jen.
Not yet?
Yeah.
No.
Close the video window and continue with your presentation.
Okay. So I think that's what I wanted to share of what we did. And there are two issues, I think, which need to be brought into focus as far as the current management scenario of the intra-articular fracture of the distal humerus is concerned. One is the approach, and the other is the way of fixation. So I'll share a couple of papers of recent literature, which are talking about the approaches and how it is affecting our management. So this paper published in August 20 from Boston compared a limited fixation olecranon sparing approach for management of geriatric intra-articular distal humerus fractures in 56 elderly patients and 30 patients were treated with ORIF, and 26 people were treated with a limited approach, where there was a medial and a lateral paratricipital dissection. And at the end, average of about 12 months, this is what their comparative results were. And they found that there were no significant differences in outcomes and equivalent outcomes in elderly patients as far as the range of motion and the other scores are concerned. So what they were trying to impress in this paper was that even if the intra-articular part, as much as you can fix, there is a certain step off, it heals by secondary intention. And another paper, and this is from Pakistan, published last year in July. 43 patients, 16 were treated with triceps lifting approach, which is similar, and 27 with olecranon osteotomy. And again, the results were same, but the complications, 2 patients suffered delayed union of the osteotomy site. So that was the additional complication that they had. So basically, both the papers are now looking at, do we actually need to do an olecranon osteotomy, and do our end results matter? So both trying to convey that without doing the olecranon osteotomy and doing the triceps to both the sides, the lateral and the medial, the end results are similar, and there is an additional chance of a non-union or a delayed union at the olecranon osteotomy site. So that was one thing that I was trying to get in focus. And the other thing was regarding the fixation technique. So what we have used is a 90-90 plating, where and this is a paper published in 2017 from Turkey, I think this is, and 24 patients, 14 male and 10 female, and a mean follow-up of 28 months. And they had good results, and with excellent results in 10 cases, good in 12 cases. And there was no instance of non-union observed in the follow-up. But when we do this technique where there are parallel fixations, this I'm showing from another case that I had done. And this has been presented in another paper from Korea in 2016. And they did an olecranon osteotomy fixation with the triangular construct with the cannulated screw and parallel locking plates, and 38 patients, and a follow-up of about nearly 2.5 years. The mean degree of flexion was significantly lower in the affected elbow than the unaffected elbow. That is a fall of about 18 degrees. But the affected elbow was still considered as functional, as it had more than 100 degrees range of motion in 33 out of the 38 patients. So their results were again classified as excellent in 12 and good in 19 patients. And they believed that the triangular fixation technique for bicolumn restoration was as effective and reliable method in the management of distal humerus. So again, the issues that have been discussed is that depending on the fracture morphology, we can use either of the constructs, that means the 90-90 construct with or the parallel plating construct with a triangular fixation. So we are open to the questions.
I think, Jayant, there are 4 issues. Number 1 is approach, whether olecranon osteotomy should be done or not. Number 2, the parallel fixation versus 90-90 fixation. Number 3 is the pre-contoured plate, which few companies are already forming, or the contouring has to be done with case-to-case basis. And the 4th thing is the length of the plates. I think that is also debatable. So on these 4 questions, I would like to invite comments from all the faculty members and the panelists.
Yes, anybody? Anybody would like to comment on this? What are the disadvantages of a long posterior approach? It is said that the gate to the elbow is at the back. So it is a very convenient approach where you can do everything. But the problem with it is that it's a long approach, long job. So sometimes you get skin edges become black and may cause a wound problem. That's the only one disadvantage, but it's a small disadvantage. However, if there are anteriorly coronal split, anterior coronal split is there, and if there is an anterior fixation is necessary, then the two small incisions, one on lateral, one on the medial side, would give a better fixation if there is a coronal split. That's the only one comment. The second comment is regarding, anybody wants to have any other comments, or should I?
Sumit, you want to comment?
Yeah. I would more often than not go in for a olecranon osteotomy and the posterior approach, especially for the type C2-3, C2-3 fractures. And type B, or probably maybe up to C1, we can go in for that, the triceps sparing approach. But apart from that, I would always, I mean, it has been shown, I mean, even the results that the papers that have been presented, none of them have actually showed any disadvantage of the olecranon osteotomy, barring a couple of cases of olecranon fixation loss. But I guess if you do the osteotomy properly and pre-drill your holes, I doubt there is going to be that major a problem with that. Yeah, Dr. Jayant Sen.
Yeah, so two comments here. One is first regarding what Dr. Kulkarni sir was saying. While I was doing my literature search, I recently came across two papers, both from the same institute in China, and they were trying to propagate a anteromedial and an anterolateral plate by doing that. But because it's a single and it was a cadaveric study, so I have not taken it into consideration for this presentation, but just for letting everyone know that people are thinking about it in that way also. And they have done some biomechanical studies to show that by putting an anterior, two anterior plates, parallel anterior plates, that they would be able to get more stable fixation. And the other question regarding what Sumit has said, so I know we are all very used to and convinced regarding the olecranon osteotomy, and very happy because you love it when you have everything in front of you. And so I will share my personal experience in the matter. I have done a few triceps splitting approach. I think I find it technically a bit more demanding than an olecranon osteotomy approach. That is my problem with it. So if it is really messed up, probably I go with the olecranon osteotomy, as you said. Having said that, this paper from Boston now tells us that you probably don't need to be that meticulous, especially in the geriatric population, regarding the intra-articular fixation. The other thing is, again, in my personal experience in all these years, not much compared to sir sitting here, but I have had two cases where the humerus fixation has united, but for some obscure reason, the osteotomy has not united. And it's a delayed union, of course, given it's a delayed union, but it is something that irks you, bothers you. So is it worth it or not? That is open to the panel.
I think Dr. Jayant said the operative word with that Boston paper is the geriatric population.
Yes, of course.
You are not that bothered about the joint going bad, a small articular step off being left off, because even if it's a small step, 5-7 years down the line, they are already geriatric population. So yes, I think for the geriatric population, a triceps sparing could be an option wherein you can probably rehabilitate them early and avoid the complication of a olecranon non-union. I agree with that. But for a general young population where you want that articular reduction to be perfect, I would still, I mean, this is again my opinion. I would request Kulkarni sir to throw some light on it.
Yeah, Yeah, but Sumit, if you see, I've gone back on my slides, the difference even in the geriatric population is about 10 degrees, right? So, I mean, we are weighing our both our baskets. And so that way, you can understand that. But my challenge with the paratriceps approach is that probably I find it a bit more technically challenging. That's my challenge with it.
Yeah.
Dr. Rajeev, you want to comment?
Or having been used to doing a perfect fixation, it leaves me slightly unsatisfied at the end of the day that probably did I not do a good enough job. That could be the way I would look at it.
Yes.
Dr.
Right.
Rajeev, you are using your finger, and Dr. Ashish, then the next one is Dr. Ashish.
Yeah, so basically what I wanted to say is that there is this triceps reflecting anconeus pedicle approach, which is a trap approach. So once you get used to it, you would never go back on the olecranon osteotomy. It is a very good approach, and the beauty of that approach is that in a comminuted fracture, when you hyperflex the elbow, all the fragments, even if they're a bit anterior, they come into your view. You have got the olecranon intact, so you can use that as a template. So sort of build up your articular reconstruction. And for me, another, I mean, this is very subjective that, at the end of a very tiring procedure, I still don't have to worry about the olecranon fixation. You just have to put some stitches through the sort of the tendon and peritoneum and you finish it. But if you open our mind to this triceps reflecting anconeus pedicle trap approach, it is a very good approach. I think once people get used to it, you will never go back on an olecranon osteotomy, unless it's of course really required. So in the last couple of years, we have not done an olecranon osteotomy since the time we have had our hands on with the triceps sparing approach. Also to add, when you have used the plates, we are talking about 90-90 and 180 construct. You have used the plates in a very good manner, and I see that you have combined the principles of an absolute stability along with a locking plate. So in the peri-articular area, this is very much acceptable. There is a 4 mm canonical canceller screw holding the articular block, and then you have used the locking plates. But there are these two out-trigger screws that you see on the lateral side that go. So if you use that to your advantage, they are really beautiful screws, and screws from both the sides in these synthesized type plates, they can sort of interject and you can have a very good interdigitation. Now, once you get that into position, you get a nice big 50-50 millimeter screws in those trajectories.
Yeah, very good.
So I've tried to interdigitate my screws. If you would look at the slide, I've tried to interdigitate my screws whenever if you can appreciate in this one, so that I can get good stability there.
I think probably the second thing that Dr. Jayant Sen talked about, that paper with the triangular configuration. Yes. I think when we talk in terms of that parallel plates, I think what I understand from the biomechanics and whatever is that those plates should be on the dead lateral and the medial aspect rather than being both on the posterior surface. The triangle needs to be on that plane rather than being on the posterior surface. It does not make a triangle. The triangle is made by the two arms on the column, on the lateral and the medial. Yes. So essentially yeah, exactly. That's the measurement.
Yeah.
And you are muted.
May I?
Yeah.
Yeah. With just one question, and which I will follow it with a comment which I heard in one of the international webinars on elbow. How soon do we want to mobilize these fractures?
So I usually start mobilizing them at about 3 weeks. I let them heal the soft tissue and everything, and then at about 3 weeks, I start mobilizing. Yeah, Sumit?
Yeah, so I wouldn't generalize it for any case. It would depend on what you have come out of with the fixation, how happy you are with your fixation, and if it is good, I would put them in an ROM brace, wait for a couple, I would say a week or so, but then I'll start mobilizing it early. I've mobilized them early.
Ashish?
Yeah.
So the trick is that what we do is we just mobilize the arm under anesthesia, under vision. And once you're confident, if you can just give them a couple of days for the soft tissue edema to settle,
exactly.
but the flexion should start immediately. That is the trick in the elbow to get good. You start the range of movement, at least flexion. If you're not confident about your extension or this thing, from 90 degree to your hand, you have to start as early as feasibly possible.
Sorry, shall I talk?
Sir, please.
Recently, in the TraumaCon 2020, at the World TraumaCon, Jupiter's comments are very interesting. He said, the reconstruction plate I use, and reconstruction plate on both sides, or one side reconstruction, one side plate, without these costly locking plates, the results are very equal. That's a very interesting comment that he made.
Dr. Pankaj?
And the person like Jupiter, whom we have to. So this is very interesting that you can do just a recon plate on the medial side and a simple posterior plate on the lateral side. And of course, the reconstruction of the articular surface must be there. Very good reconstruction is the must. And early mobilization is the trick of the trade.
Yes, Dr. Pankaj.
Yeah, Ashish, you said if the elbow does give you confidence intraoperatively, then you would want to mobilize immediately. What if it does not?
Then it's a problem. Then you sort of augment the fixation. So you go back on the fixation. Something is going wrong somewhere. I mean, if it's really a bad chura which you can't do, fortunately, I've not been in a situation like that where I can answer your question confidently. How the fracture is really bad that you have to put a fixator and come out. Then maybe yes, things may be different. But yes, something is going wrong with the fixation. Maybe you augment a couple of screws more or suture fixation, whatever you feel like.
Yeah, so I would just share a very, very nice comment by Mr. Osterman, who is a very, very big name in upper limb surgery. He said, one, we are all have this fixation of early mobilization for intra-articular fractures, which is what AO has taught us over many years. And we have been applying it to the elbow as well. He said, when it comes to the elbow, it's much better if you are not confident of mobilizing, and if you feel early mobilization may actually lead to loss of fixation, then you are much better off maintaining the anatomical alignment until the fracture has become gummy, and then start working on a stiff but well-reduced, well-aligned anatomical elbow. That is a much better situation than you start mobilizing early and then you have a mechanically not well-aligned elbow to work with. The outcome of a stiff elbow treated by arthrolysis as a secondary surgery is much better than an elbow which is anatomically not aligned to start with. So I think that was a big eye-opener for me, because I had a fixation of early mobilization of intra-articular fractures. But now I would look at these things little differently. If I'm not very confident of how the fixation is holding, I would not hesitate to delay mobilization for 3 weeks. I think Sumit said 3 weeks. Sumit or Jayant said 3 weeks. I would be very after I heard him, I think it's a fantastic way of looking at elbow fractures little differently as compared to many other intra-articular fractures.
Rajeev, you were trying to say something?
Yeah. There was a concept of Mayo Clinic parallel plating, where they use maximum screws through the plate in those fragments, the condylar fragments, and not separate screws. And you first fix it, the metaphysis, and then put those screws in the condyles area, which are kept reduced by K-wires only. And that gives a very solid fixation. And I have been able to mobilize them very early without loss of fixation if you get really purchased through the plate in those condylar fragments. So this is what I felt.
Yeah, this is the Oderstolz concept, that the Oderstolz concept is that only, that every screw should be a plate, and as long as screws as possible and as many screws interdigitating, so that it kind of becomes an angularly stable construct.
That's true. And you have to mobilize it early. That is the concept. If you really immobilize it for a long time, then the purpose is partly defeated, I feel.
I think I also agree with Dr. Pankaj, sir. Sorry,
Yeah.
Dr. Kulkarni, sir, please.
The intra-articular fixation must be fixed very, very stable, and so that early mobilization is very necessary. And rather than doing a second fixation of the arthrolysis, I would do a better fixation of the intra-articular and then start mobilizing. Some here and there. In that your surgery, you must test it, the elbow movements, and if you find it little unstable, you fix the with the external fixator for some days. The problem with external fixator is a better one. Orthofix fixation has a hinge. The hinge should be collinear with the axis.
I think we are.
I think we have lost Kulkarni, sir.
Yeah, we have lost
connection.
Kulkarni, sir, and I think we should move on to our next case.
Yeah.
If you can start sharing your screen till the Kuldeep is joining us again.
Kuldeep is there. Or you want me to share? I'm fine with it.
Kuldeep,
Yes. Kuldeep is there.
Very good morning, everyone. First of all, I would like to thanks ROSA and BOA and Maharashtra Orthopaedic Association to invite me to present my case.
I had some problem with the net here.
Sir. Morning, sir. I will be discussing one or two cases. Both are interesting. One is scapula and another is a proximal tibia. If time permits, I will share my screen. So, is it visible to everyone?
Yes, sir.
Yeah.
Yes.
So this is the first case. Here is an 18-year-old male who met with an RTA and had this fractured scapula with glenoid and also had a fracture D11, which was neurologically stable and only 10 to 20% of compression. So this is his X-ray, and proceeding for the further investigation, we got a CT scan done, which clearly depicts glenoid fracture at equatorial region with scapular body fracture, which is Eidberg type 5A. So I would like to ask the moderators that considering the further management for this case, should we conserve or should we operate? This is the CT scan I will keep putting on this slide.
Yes. Anybody? Anybody would like to comment? No, this is an
intra-articular fracture.
Yeah.
It's an intra-articular fracture through the glenoid. So yeah, I would go in and operate upon this.
Yeah.
Even if I just forget about the Eidberg scaphoid fracture, even if it's just the glenoid, I would go ahead and fix the fracture.
Yeah, this needs definite fixation, no doubt about it.
Yes. So
the approach, yeah.
So
approach
coming
is very
to
important.
approach and exposure, so I would like to ask one of the moderators who are doing these kind of cases that what is the current choice of approach nowadays for these kind of fractures?
Yes, anybody? Now we have shifted from the extensive approach to a medial along with the border of this and go up to this and then separate the deltoid upwards. And sometimes you may have to cut the teres major tendon, and then you can reflect, you can see the glenoid as well as the lateral wall. You can go from the glenoid to the lateral wall and you can fix it.
Yes, sir.
That's a modified.
So you're talking about modified Judith approach, right, sir?
Yeah, modified Judith approach.
Yes. So that is the approach of choice. And I will directly go to, we will discuss this reduction sequence tips while discussing the surgical part. So at this point, I should discuss what is the choice of implant for these fractures. Because scapula is one bone, which is just like iliac wing and acetabulum, wherein we have good bone stock at the neck of the acetabulum, at the lateral border of the acetabulum. Simultaneously, the body is very papery thin, and the medial border is very much variable thickness. And even the spine is also having very variable thickness. So in these fractures, what is the choice of implant people are using?
We are using 4.5 plate and sometimes a recon plate. If we can manage with the plate, it is good, because plate is little more stronger than the recon plate. But recon plate, 4.5 recon plate also equally good. It doesn't need very strong implant.
Yes, sir. It is a non-weight bearing bone.
Yeah.
And moreover, just like a shoulder girdle. So we just need to stabilize these fragments.
Yeah, just we need stabilization and a lag screw fixation of the glenoid.
Yes,
glenoid
sir.
should be nicely fixed. Yeah.
So you have taken the point, sir. Lag screw fixation is the key here.
Yeah.
Yes, Sumit.
Yeah, lots of screw options and a recon plate essentially.
Yeah.
Yes, yes. So I think scapula is one fracture wherein we should keep our armamentarium ready from 2.5 to 3.5 to 4.5, all three type of plates, where we go in and we look the thickness of the bone, and then we should have cortical and cancellous screws in both the sides, and then lag screws definitely, as sir has rightly pointed out. So this was the position of the patient. It is a floppy-lateral position. As you can see, the incision has been marked. It is a modified Judith approach, and once we lift the full thickness flap of the deltoid, we are going to directly bang upon the lateral border of the scapula. So our workhorse or our window for working on the scapula, body and neck is basically lateral border and the neck of the scapula, where we create an interval between infraspinatus and teres minor. There we encounter a few blood vessels, circumflex humeral artery. Either we need to ligate it or we need to cauterize it, and then we can directly work upon the posterior border of the glenoid. Any questions, sir?
Yeah, that's right.
So once we approach here, so we just need to create a gap between the teres minor and infraspinatus, and we need to go rightly upon the superior border of the scapula and the neck of the scapula. So the key here, as Kulkarni said, has rightly pointed out, is to fix the glenoid. The priority is glenoid because it is fractured obliquely at the equatorial region. We need to put something like compression screw or a lag screw, as he has rightly pointed out. So what I did this, that I opened through modified Judith approach. I created an interval between the spinatus and teres minor, and first put a lag screw, 4 mm cannulated screw with a washer. Once I recontact the glenoid, and the direction of the screw was, it is perpendicular to the fracture. If you see here this image, if you see here this end-on image of the glenoid, so my screw direction was from dead inferior to the superior at the base of the coracoid, from the coracoid starts. So that should be direction of the screw to get good anatomical and equal compression on the either poles of the glenoid. So once we do that, then we need to restore the lateral border. So coming to the restoration of lateral border, we need to neutralize with something like a neutralization plate, which is a kind of, we have now locking plates. Here I have used a plate from a distal radius set, where you can see that dorsal plate of the distal radius, which is L-shaped, having 2 screws in the distal bone stock and then 2 screws in the proximal bone stock. So after restoring the lateral border, it is not essential to go to and fix on the medial border, but if you feel it is unstable, and if you have a good bone stock on the medial border, which is very much variable in scapula, you can put a small plate just for the sake of neutralization and restoring the bone of restoring the shape of the scapula. That's it. But it is not essential to fix the medial border. So this is the post-op X-ray. This case has been done in 2017, and these are the functional outcome 6 months post-op. So patient still using the brace here, and you can see all range of motion has been very well restored, and he has gone back to the laborer work. So before going to discussion, these are the few principles which I would like to highlight. that in this approach, what is most important is to create a full thickness skin flap of the deltoid of the deep fascia and cauterize all bleeders, because postoperatively we reflect a large flap. So there is a common complication of hematoma, and then erase deltoid only as much as possible from the spine of the scapula, develop intramuscular plane between infra and teres minor, ligate and cauterize ascending branch of circumflex artery before working on the lateral border or back of the neck of the glenoid. And when working on the neck, stay on the bone and stay in the subperiosteal plane. That is the key, because there are neurovascular structures there, infraglenoid region in the axilla. So we need to be bang upon the subperiosteal plane and restore glenoid first and then come on the lateral border. So the case is open for the discussion to all the respected moderators and seniors.
You are nicely shown everything, very nicely.
So I think, sir, what I would like to highlight that glenoid fractures, I don't know, for some reason when I was doing post-graduation 15 years back, I have not seen so much, even in my residency, though I did it from Delhi, one of the prestigious institutes. But still nowadays, I'm practicing in a small town, Bhilwara, Rajasthan. Every month I'm encountering 3 to 4 glenoid fractures. Out of them, 50% are intra-articular. So somehow the mode of injury, the kind of velocity people are encountering, it has changed even in hip, knee, tibia, shoulder, everywhere. We are getting these kind of fracture very frequently, and we should be able to fix them, especially in young population, to bring back to them to normal level of function.
They've heard your name, Kuldeep. That's why you're getting so many.
No, not like that. So shall we go for second case, sir? It is one more interesting case. If Kulkarni, sir, you permits me, shall I go for second case?
Go ahead.
So there is a second case, sir. This is a split depressed fracture medial plateau with PCL and lateral collateral avulsion. So although these are digital x-rays, but not very clear, because after this x-ray, I got the CT scan of the patient done. So here is a 22-year-old male met with an RTA at a closed injury of the knee. Skin and soft tissues are fortunately within normal limits. Knee is unstable in coronal plane, completely unstable, because medially there is a depressed fracture and laterally the lateral collateral is avulsed. Anteroposteriorly knee looks to be stable and there is no neurovascular deficit. I subjected the patient for CT scan, and these are the 2D images of coronal, sagittal and axial cuts. So if you read the coronal images, the medial plateau, medially it is significantly depressed. The lateral part is not, but splayed. So the lateral part is splayed. The medial part is obliquely depressed in the coronal plane and significantly. And if you see the sagittal images, then the articular surface of the medial plateau is comminuted and the PCL is undisplaced. The PCL here is undisplaced, if you see. And these are the axial cuts wherein we can make out that the splaying of the medial plateau in between the depressed and the medial splayed surface is more than 5, or you can here it is more than 5.7 millimeter. So these are the 3D images. In this kind of fracture, 3D images usually don't give a clear clue. But here what we can notice is that this is the PCL avulsion, which looks to be in the crater and well placed. Here you can see a small place of head of the fibula where lateral collateral get attached. It is avulsed, significantly displaced. And if you can see this anteromedial corner of the tibia, here you can see that the knee has gone in hyperextension and varus. While injury, this shows that knee has gone in hyperextension and varus. So this anteromedial corner is displaced. Here it is more clear in this another oblique view of anteroposterior oblique view. So coming to this, after understanding this fracture, which is unstable in coronal plane and having intra-articular step, I should ask moderators, I would rather take their opinion, what is the approach we are going to take for this patient?
Yeah, let us have the different opinions.
Yes, sir.
Yeah, anybody? Anybody would like to volunteer? Please. Go ahead.
I think I would go in for primarily a posterior medial approach, and I would also probably need a window towards from the lateral side and use it to elevate the more medial part of that sorry, the more lateral part of that medial condyle, to elevate it up, go from the posterior medial aspect, reconstruct, use a couple of racks to align it, and then put in a plate. I wouldn't necessarily do anything for that PCL chunk. It is more or less in its place. And then come around to the lateral side, open it, and use probably an anchor or something to pull down that LCL fragment and stitch it onto it. Yes.
Why do you want to leave the big posterior fragment which is attached to the PCL? It's a big fragment. Don't you want to?
It is not discrete, and it's got a large bony chunk with it. So if we can align everything around it and keep it in a brace with a PCL, just a little bump, I am hopeful that it should heal. Even if, yeah.
I would do a LUA approach, posteromedial, and posteromedial fixation is a must because there is a big posteromedial fragment. But with the same approach, you just go medially, centrally towards the lateral side, and you can fix that also. One lag screw would be all right. That is with a plate. If you can play with a plate, the same plate can be used there also. With a long.
Sir, are you putting the patient prone or?
No, you can do floppy lateral or even prone.
4.
Floppy lateral also would do. Floppy that, and then you can do this.
I usually tend to do my PCL levels from the prone, so that's why I was a little wary. So I was a little wary of doing it from the floppy lateral. Getting the direction of the screws, at least in my hands, it's a bit tricky. So I tend to do them prone per se.
Both are, it depends upon the surgeon. You can do a prone approach and you can turn it back again and go anteriorly if necessary. In this case, a small anterior plate also would be helpful, I think, because there is a depression in the central part of the medial condyle. We need to elevate that. And then a small plate would be anteriorly also. Would you agree or no?
Yes, sir. Yes, sir. Dr. Ashish would like to say something.
So, extending Sir's argument about Leo's approach, that the same group has come up with an extension of their previous article in 2 articles, and one is presented very recently. So, what they say that they have drawn these fracture lines and they have assessed the mode of failure of the proximal tibia. So, if you see the medial condyle has failed in compression and the lateral structure has failed in tension. And even the PCL. So therefore, I would agree with sir that I'll go by Leo's approach, because in a single approach, I can tackle everything medially.
Yeah.
And whatever is fractured, let's say it's fractured in compression, you need to elevate that, and you need a buttress plate. If it's fractured in tension, you need to fix that and a tension band plate kind of thing. So
no, would you fix the medial fragment or not? That is the question.
Yes, sir. Definitely, sir. So probably I am expecting 2 plates medially. So one, as I lift up the gastrocnemius, you can put a lag screw to fix the PCL fragment, but you can just neutralize that by a simple 2-hole or a 4-hole DCP or a recon plate. You come anterior to the pes anserine insertion where the anteromedial compression is. Through the fracture side itself, you can elevate, maybe put some bone raft and put like the raft construct which is there. The Synthes also have a medial plate. And then if you are doing it in a floppy lateral position, the advantage is that you can just take a sandbag out. You can flip the patient in a figure of 4 position, address the medial side. You can turn the lateral side. Lateral side will be not through a window. I think it will be a more extensile approach, because though the fibula is avulsed, you will need to visualize it clearly before you place your anchor or a screw or whatever.
Here,
lateral window was just for elevating the fragment. For the LCL fixation, yes, you will have to do a formal opening.
So that's correct.
What about anteriorly? Is there any approach anteriorly? A small plate is necessary or not?
Yes, sir. If you see these images, sir, there is a axial images shows a clear splaying of the fragment here. But once we apply a medial plate and elevate the articular surface, this splaying is corrected. And then we need to decide whether we need to put a buttress plate or we need to put a raft screw, something like independent raft screw. So as we use a civil construction principles in orthopedics, that once anteriorly we don't have a articularly anatomically contoured plate, so sometimes we can use a perpendicular raft screws, one going anteroposterior and one just below it going medial to lateral. So they are like two beams perpendicular to like this, one going medial to lateral and one anterior to posterior. So what I did was this, that I use a dual approach, rather you can say three approaches. That this is the post of X-ray, you can see. So I did the posterior in supine position. My sequence of fixation was, first I fixed the lateral collateral, which I used an anchor with 4 threads with it, with needles preloaded. So these needles, they can anchor the bony fragment from 4 different corners because they are preloaded into the suture. And then I can tie it and get a compression. Once I restored the lateral stability, then I went medially. And medially, as lateral collateral, as PCL was undisplaced, so I didn't touch the PCL. I just corrected the splayed part. I just corrected this part, splayed part. But I noticed that articular surface was not getting elevated from the fracture side posterior-medially. So I took anterior approach and I went through anterior suprameniscal arthrotomy. So you can see here, sir, this is the femoral medial condyle contoured, and here you can see the medial part of the tibial plateau, which is gone inside, and this is the lateral part of the tibial plateau, which is compressed with my finger, but still the medial is depressed. So I distracted it again, splayed it again, put an artery here from the upper part of the medial meniscus, like how we do submeniscal arthrotomy in the lateral joint. I did suprameniscal arthrotomy into the medial joint, elevated this fragment which is attached to the base of the ACL, and then again corrected the splaying and compressed it and used this plate. So once I used this plate, I compressed it. But then, as you rightly said, that anteriorly there was a risk of sinking in. So above the plate, I used this screw, and to counter the sinking of this screw, I used this screw second, which is anteroposterior plane. So my second screw is again acting as a lag screw for PCL attachment site also, which I reduced with finger and did this and did this. After doing all this, patient has a significant postoperative stiffness, and he went through a rigorous physiotherapy. And finally, this was the outcome of the patient at the end of the 9 months.
Very good. Excellent.
So usually we do encounter lateral plateau depressed and split fractures, but encountering medial split depressed fracture is very rarely, and this was the first case for my for me. And after this, I have not done any other case. So here I would like to say that the LCL fixation is most important, and we have so many variable options for fixing LCL. But nowadays, a small 5.5 or 5.4 suture anchors, which are corkscrew anchors types, which get good hold into the cancellous bone of the fibula and has 4 preloaded threads, which are fiber wires and needles loaded with it. We can fix all the ligaments with them very nicely. Medial plateau needs reduction, so don't hesitate to open the joint and reduce intra-articularly as accurate as possible, because sometimes we try to reduce proximal tibia indirectly by putting holes and temping with them, templates, and putting temper, and then seeing under C-arm, getting exposures, and accurate 3D vision in C-arm is not visible. So always open the tibia. It is accessible from all around now with different techniques, as you have already discussed. And post-op rehab is most important when we open the tibia from either sides. And our physio should do a real hard work with the patient to get such outcome.
Only one comment. You have not fixed the PCL fragment?
No, sir. It was the PCL was partly compressed with this plate, sir. As you can see here, sir, this is the prone view, sir. This is the back side of the tibia.
Your plate is on the medial side.
Yes, sir. My plate is on posterior medial side, sir.
You could have put just one lag screw at least.
Sir, I tried to put this lag screw. This is holding, sir. This anteroposterior lag screw.
Oh, not anteroposterior. You have
because, sir, I did this in supine position.
Oh.
So in supine position, it becomes difficult to put a screw from posterior to anterior unless we do either figure of 4. But and in figure of 4, because
your approach was posterior medial, no?
Yes, sir. Posterior medial. You can
posterior
see, sir,
medial approach.
Sir, these staples are for posterior medial approach.
How do you do with the supine position posterior medial approach? You have to make a floppy lateral.
Sir, I put two bolsters, one below the knee proximally and one at the site of ankle. And then I do it. So I am now habitual to do it in supine position.
So I would feel that you should take a posterior medial approach.
Yes, sir.
And from there you go not lower approach to the lateral, full lateral, but just up to the center of the tibia, and fix that fragment with at least one lag screw, because that is a PCL fragment, which is important.
Yes,
because with the movements, it may move up and down, or PCL may become weak. So you have a chance to fix it.
Yes, yes.
You just fix it with a plate, with a lag screw, or even a small plate. You know, nowadays the current tendency of treating all these fractures is to use small plates at different. Even you can use 2 plates, 3 plates, but small plates, even a distal radius plate, or sometimes a thin plate.
Yes,
you use it and fix all the fragments.
That
so
is
anteriorly also, you should have a small plate, just a 4-hole plate or a distal radius plate, something. So it gives nice buttresses to the fragments.
Correct.
Instead of just putting one lag screw, you just put a small plate there, and that will give more stability, so that you can mobilize the fragment early. Of course, you have a good results. Success is nothing like success. So you have got a very
Yes,
good
sir.
results.
You are absolutely
So,
right that the trend is of fragment specific fixation. So as many fragments we are having in our weight bearing or mechanical loading zones, we should try to stabilize them with plates and good stability to have early weight bearing and early range of motion.
That's right. Very good.
So that is the reason, sir, the physiotherapists took a lot of time, because I immobilized this patient because I did not fix PCL with confidence. So I immobilized this patient for 8 weeks. And in 8 weeks, the knee got real stiff.
Yeah.
And my physiotherapist took 6 months to get this movement.
Yeah, that's right. You know, you have got ultimately good results. But if you had fixed all these fragments with a small plate, this physiotherapy would have been very, very easy. Within 6 weeks, the patient would have got everything.
Very
that's
true,
the only comment. Nowadays, you can use 2 or 3 plates or even 4 plates, but fix small plates, but fix them nicely.
Correct. That is the message for this fracture.
Yeah.
Yes,
Sumit.
A very good case.
Would you have liked to add one more rat screw, or you're happy with that one rat screw?
No, I would add 2 or 3 rat screws.
That is one little comment I would like to say.
Yeah,
I would have probably preferred at least one more, or maybe 2 more, 1 or 2 more.
So,
through the
so
medial plane.
You can use a raft plate also.
Yeah,
so
exactly.
Yeah.
I'll tell you, sir, medial, there is no raft plate, sir. There is no raft plate for medial tibia still. I think one of we should design anatomically contoured raft plate for medial plate too, because these plates were what we use on lateral side. Once we use them on medial side as a raft, the screw goes and hits the spine, tibial spine, and they don't support the subchondral region, what they are supposed to do it. So that is the big.
But at least 2 or 3
freehand raft too. Yeah.
No, so if you see here, this I am moving a cursor on this bone. This is a lateral medial plate to lateral aspect. So this was a single bone with good subchondral bone stock. Patient is young. Because if this would have been split in coronal plane, I may have used 2 raft screws. As it was a single piece, this was a single piece. So I relied on a single screw, because another screw which I was put, this screw, I put retracting the MCL here. So I retracted the superficial MCL and I put this screw. This is below the MCL. If I put a 1 screw here, then I have to put it above the MCL, which adds in my stiffness. So as we know, we are doing arthroscopy. So a lot of things while doing surgery goes in our mind, that post-operatively MCL beech mein aayega, ye beech mein aayega. So I relied on 1 screw.
Right. One more comment I would like to make is you may use a Lewis classification or a modified Chachkar. Recently he has approved. You may use it. But one more morphological classification has come up. This morphological classification is a slope type 1, or a whole plateau type. That the whole plateau is depressed. So that is called a depressed plateau type. or border type, only the border is involved.
Yes, sir.
Or in this case, as you see here, it is a sunken type. The central part of the is like a sunk in the
Yes,
kitchen
sir.
sunk, you know, like a kitchen sunk, the central part is depressed.
Yes,
so
sir.
if you classify this, then you know how to do the during surgery, it will help you. If it is a sloping type, you elevate it. If it is a depressed type, you elevate like that fully. So like that. So it is one more classification which will help you in the during surgery.
Right.
Morphological classification.
Kuldeep, in literature, there are so many reports are there use of arthroscope while fixing these kind of fractures. What is your comment?
Sir, I have done quite a few cases, arthroscopic elevation of the lateral plateau, but there we need to ensure few things before putting arthroscope. That number one, the periphery of the tibia and the femur should not be breached, because extravasation of the fluid is one big complication. You need to be dead and short. And second thing, once you put scope, then you keep palpating your calf and you should be really fast to elevate and come out, because your time of the surgery, your time of the fluid inside the knee should be as minimum as possible. So if you are able to deal these two things, you can definitely elevate all intra-articular fractures arthroscopically and then fix percutaneously either with the screws or MIPO sliding biological plates. That is technique, but I think that have a good learning curve. I am still into it. And because the complications associated are very they are very worrying, because you get post-operative compartment, then it is difficult to explain it. And moreover, we have open techniques which we have been acclimatized very well, like suprameniscal arthrotomy, submeniscal arthrotomy, and tibia can be assessed all over. So the fracture personality decides whether to do arthroscopic elevation or open.
Okay.
Thank you.
Shall we go to the
both? Next one. So thank you, Kuldeep, for the excellent cases.
Very nice case. Very nice case. Nicely discussed. Very nice.
Thank you, sir.
So you unshare your screen. Now I would like to invite Dr. Sumit Banerjee to present his case. Sumit.
Yeah. So am I visible to everyone?
Yes, Sumit.
Yeah. So so I've got essentially a few cases wherein I've taken through the spectrum of the disease. Is that all right? If we have time, can we go through that? Hello. Is that all right, Dr. Rahul, if I take you through a series of cases, a couple of cases? Yeah. All right. So the first case is a 40-year-old male. He was an electrician. He fell down a flight of stairs and presented to us 7 days post-injury. It was a closed injury and his distal neurovascular was intact. So this is the X-ray. So this is essentially a medial condyle fracture, a unicondylar fracture of the distal femur, 33B2 essentially. At this point, question to everyone, any further imaging or is this enough?
It's better to have a CT scan in all the intra-articular fractures. But you will be surprised to find some more information.
Thank you so much, Kulkarni sir. That's exactly what we did. So this is the axial cuts and the title and the 3D recon. So it was essentially a unicondylar fracture. So now coming to the treatment options, the approach. What approach would everyone like to use? Would this be amenable to the standard anteromedial approach, or would anyone like to go posteriorly or anything?
Yes, go ahead.
Ashish?
Can you show the image again?
Right.
Yeah. So I think this is a fairly large chunk just for the pure screws, but I would be able to go through a standard anteromedial approach and even put a buttress plate if the time, we would need that. The lag screws will be with really strong lag screws like a 6.5 millimeter cannulated cancellous screws, which will hold it in position. And then I would buttress that.
Ashish has essentially answered all my questions in there, just one straight sentence. That was essentially the whole aim of showing this case, that this would probably, since it's a very vertical fracture, it would probably need a plate in addition to the screws. And the screws, especially the cannulated screws, should need to be the biggest size possible you can get to avoid a strength. So this is what we did. We tend to use this ball and spike clamp a lot. So these are the cannulated screws that we have put in. And then I just added in a buttress plate over it, a T buttress plate. And this is the final fixation. Any comments on the fixation? We use the anteromedial approach, and that extra staple, couple of staples that you see there are those are for the clamps that we had put in to sort of hold it while we were reducing the fracture. I find that it is a very good tool to help you in the getting a perfect reduction.
No, why did you? We can use a T plate or a L plate and pass the screws through the plate, lag screws through the plate, and then put, buttressing is absolutely necessary. Buttress plate is a must, because the medial condyle is the tremendous forces are acting on the medial condyle. So medial condyle buttress plate is a must. But I would pass the screws through the plate and put a plate.
I think passing the screws, sir, that's a good point. I think passing the screws through the plate, the problem is that when the screw size gets limited, you'll have to use thinner screws then. And that is what brings me to the next point. So this is an article which talks about that the buttressing obviously improves your strength and it allows for early rehabilitation. They also say that biomechanically that the thicker screws, the 6.5 mm screws, is very good to provide the strength, and the passing the screws through that plate would limit the size of the screws you can use. You would probably end up using a 3.5 or a 4 mm screws, and they might not be able to give you that much biomechanical strength. So that's why I use a lag screw separately and then buttress it with a plate.
Okay.
Anybody else would like to comment on anything?
Go to the next case. More.
Yeah. So yeah, this is just a starter one. So one thing I would like to do is probably I think we have put in a few more screws than needed in the buttress.
Yeah, that is not needed.
Yes, and that's why you can see a bit of a stretch shielding going on at about 6 months. It's healed perfectly. This is his range of motion, and that's his essential range of motion. So lucky, good. So we move on to the next one. This is a 60-year-old male, came in with a road injury, again a closed injury, and that's his X-ray. So this is essentially an OTA type 333C. Now what C it is, I think we would need a CT scan for that. Presuming everybody agrees to that this would definitely need a CT scan. So these were the axial scans. These are the axial CT cuts. And you can see there is a clear HOFAS component there, and also a slightly oblique intra-articular component in the lateral compartment. Those are your coronal and the sagittal sections. There is a step off in the coronal section, and the sagittal you can see the nearly vertical HOFAS and slightly more oblique component in the lateral femoral condyle. So again, the salient points about it is the plate length, the screw density, what do you do with the metaphyseal segment, and finally, whether you go in for an extensile approach or a MIPO procedure. So these are the intra-op CM images. So as you can see, we've used Herbert screws to reduce the intra-articular fragments. The lateral component was a bit oblique, so we have tried to go perpendicular to the fracture if possible. So I've used the lateral screws are a little more oblique, while the medial screws are a lot more horizontal. Once you have done that, then you put in a plate and see it on the lateral X-ray. It's very essential that your plate sits at a particular position on your lateral X-ray. If it is too posterior, you can end up with the golf club deformity, and your top screw also goes off. So it's very essential to put in provisional K-wires to hold it, and put in the final, the topmost screw, just put in a wire to hold it. And then you can do the articular, do away with the opening of the diaphyseal segment and do it with a MIPO or a less mechanism. So this is what we ended up doing. This is the final configuration. Any comments anyone would like to?
Yeah, this is still the plate is a little short. Now currently, the longer the plate, the better it is. Then the proximal screws, the position of the screw is very good. The distalmost screw of the proximal fragment is well placed. Yeah, that's very good. But there is no need for how many? 4 to 6 screws are not necessary.
Yeah.
3 or 4 screws maximum.
4 screws.
And longer plate, that is necessary. Now, in spite of all doing good things, this might do well because there is not much of a medial comminution. There is comminution, but there is no gap as such.
Gap, exactly.
But even then, this fracture may trouble you. So that is why we now are doing dual plating. Dual plating has come up in a big way for the distal femur. You are taking, this is a well done, except these 2 comments, that longer plate and few screws. But I would add a small MIPO plate going from the medial condyle slightly anteriorly and fix 2 or 3 screws percutaneously and fix 2 or 3 screws distally. So dual implant has become the important point today. Dual implant may be 2 plates, or even you can do a nail and a plate.
So sir, would you do a medial plate in almost every distal femur with a metaphyseal comminution, or would you reserve it for the ones that have a gap?
If there is a medial comminution, severe comminution, and if there is a gap, the gap you can, we have classified the gap into 4 types. Now this is the one, is a type 1, in which you can see the medial wall. It is not gap, there is no gap at all. Or comminution may be such that you get 1/3 of the gap or even half, and then it may be just full gap also. So there are 4 types. So if there is a full gap, of course the treatment entirely different. If there is a this case and the one, it is better to put a medial plate. And the gap is different. That's a different story altogether. You may have to do something else, grafting, etc. So in this case, we do nowadays routinely a medial plate, dual plating.
So I tend to do medial plating if I see a gap. Unless, of course, just a type 2 kind of a gap. For a 3 or 4, we'll do a different thing. So I tend to do it on a type 2. Anyone else in the panel, everybody, their views on dual plating? Ashish?
Yeah, this is very controversial.
No, I agree with sir. And the place where we practice, we are neighbors with Dr. Mukhi, who since a long time has been a very, very vocal proponent of bipillar plating, or let's say, a strut on the medial side. So he even goes to the extent of putting a Harm's cage. I mean, he's shown his x-rays in quite a few conferences. So he puts a Harm's cage or a fibula or even tense nail on the medial side to buttress that. Now the problem here is, as sir said, because of too many screws, there may be a possibility that the medial side may go into non-union, even though the lateral side is good, and then the construct becomes a bit stiff.
Yeah, and this may break also.
Yeah.
So that's the exact reason why I put on these X-rays.
Yeah.
So these are 2 articles. One is from the JOT and one is from the OCNA. So the Persian pitfalls, again, you have to be careful about the positioning of an implant. If you go too posterior, then the golf curve deformity happens. Longer plate with lower screw density. That's what Dr. Kulkarni and everyone has been emphasizing. So I think now the concept is, if you've got a metaphyseal comminution, your plate should essentially be at least two times the length of that comminuted segment per se. So that's how long a plate you really need to go. And another thing, 2 to 3 times, yes sir. That's what I said. Minimum of 2, at least go above that. Secondly, avoid. So the one more thing I wanted to draw attention, that avoid all proximal screws as locking screws. So a mixture of locking and non-locking screws in the proximal fragment is very essential. thigh pain and a high risk of periprosthetic fracture in osteoporotic bone has been seen with the proximal most screw. So either keep it non-locking or use an unicortical screw. That's a very good way to avoid this. The concept of slightly less rigid fixation and the newer concept is that of a far locking screws are being utilized to avoid a more uniform callus formation across the medial and the lateral bodies. So that can be done to reduce the rigidity of your construct. So this is at 6 weeks, this is at 12 weeks. Fortunately, he went on to a union. He's got a good union and he is pain-free and ambulating full weight bearing. He's got an excellent range of motion. So the next case, this is a 52-year-old male. He was a PWD staff. He was involved in an RTA. He came to us with an open wound over the anterior distal thigh, 2 by 2 centimeters. He had facial injuries as well. He had an undisplaced fracture of the lateral wall of the orbit and zygomatic apse and some component of head injury as well included in it. So this is his X-ray. So essentially, again, this is a type 33P and P3 essentially. So we went in for a, so the questions are initial management. Would everyone agree that we need to fix this as soon as possible, or would anyone like to wait? Or
CT can be done immediately.
Yeah, definitely a CT scan. Timing of the surgery. So we wanted to operate him as soon as possible because of the head injury and stuff. We got the clearance came around about 72 to 96, 3 to 4 days later. Approach again, standard anterior approach going down to the tibia, up till about the tibial tuberosity. Anyone else? Any other approach they would prefer for these cases? I'll show you the CT scan. So these are the sagittal cuts. We are going from medial to lateral. These are your sagittal cuts. Okay. That's your coronal cut, and there is a cortical fragment that is incarcerated right in the middle of everything. Those are your axial cuts. So once again, coming back, timing of surgery and the approach, what would the esteemed panel have their opinion about in such cases?
In the distal femur, there is no need to wait for anything. We can do as early as possible. Because if you keep it more longer, the fragments move and there is inflammation and then swelling it becomes more and more. So in distal femur, the earlier the better.
Anybody else with any other opinion? Yeah. So this patient is actually from a colleague of mine, the same unit as us. So this is the intraoperative image. We went for the standard anterolateral approach, extended it down. That's the incarcerated fragment that's been fished out. We did the intra-articular reduction with cannulated screws and then put in a neutralization plate. The plate was put in a MIPO mode, so the articular fragment was closed and reduced perfectly and anatomically, and then we just bridged it across. That's the wound post-surgery. That's a surgical scar. We do put a drain every time, and that's the final picture. Again, any comments about the final implant fixation?
There is a real very controversy regarding putting those 2 screws in the fracture zone. The fracture zone need not be disturbed as far as possible. You should not open it. Have you done it by open reduction or?
Yeah, this was an open reduction. We had to, because there was an incarcerated fragment inside, so we had to take that fragment out. It was incarcerated between the intra-articular fragments, so we had to take it out.
Acha. So these 2 screws are the controversial point. Many people say that you just bypass the fracture zone, do not open it. You just bypass the fracture zone, take as long as plate as possible, only maximum 3 screws, and you may add on the medial side. That is again a controversial issue.
Thank you so much for raising that point. That was the exact idea of putting on this X-ray.
The objection to putting these screws, you have put a lag screw, isn't it?
Yes, this is a lag screw.
Yeah, when you are putting a lag screw, when you put a lag screw, that means you are aiming at an absolute stability.
Absolute reduction.
Now, when you are aiming at absolute stability, your plate should be a protection plate or a neutralization plate.
Yeah.
This is, you are using a bridge plate.
Yeah.
Yeah, the bridge plate cannot act as a neutralization plate because the bridge plate has some mobility. So that is the two contradictory things have happened. So that is the reason why lag screws are not used in this fracture zone. You leave it. Don't try to anatomically reconstruct. It is not necessary to do anatomical reconstruction when you have done anatomical reconstruction of the articular cartilage is a must. That is a must, but not necessary to do the distal comminuted area. A1 to A3. A3 is not necessary to do lag screw using. You can put as I told you, you can put just a small plate there. That's my call.
So, yeah, absolutely. That is exactly the reason why I've took this case for this discussion itself. Because once you open it, you tend to have that urge to align everything perfectly and fix all the screws. So that is the cautionary tale here. So this is a very good review article in JOS. This was published in 2019. So now MIPO is almost standard. Titanium plates again are standard because they have a modulus elasticity that is closer to that of the bone. So it is very essential to allow a less rigid construct. Now, most important thing is that even if despite using a longer plate, it is the distal most screw proximal to the fracture that decides the working length of the construct. So no matter how long a plate you use, it is the distal most screw that will decide the length of the construct. So that needs to be as proximal as possible. So that's the reason. And as Kulkarni has already pointed out, avoid intrafragmentary screws in the metaphysis unless it's a simple oblique fracture, and more importantly, your screw is in a different plane to your plate. If it's in the same plane, then it is not acting as a neutralization plate. That's what the concept Dr. Kulkarni has said about. So this is what has happened. Right?
One more comment, Sumit.
Yeah.
In the proximal portion, would you like to fix 8 cortexes or 10?
4, only 4 screws. 4 screws are fine. In fact, not even 8, even 7 would be fine. 3 bicortical screws and 1 unicortical or a non-locking screw would be fine enough.
Everybody agree with me, or in every case these 7 cortexes are it?
Yeah, I agree with you. You can use 2 screws, just conventional screws and 2 locking screws. But the plate must be still longer plate. That is very important. And again, this is going in for non-union.
Yeah, this is going. That is the reason why I put this on, because
that is the reason. That is because
the articular fragment has united, but that lag screw.
Yeah, because the principles is different.
Yeah.
Here, lag screw is not supposed. You are not supposed to. Some people are doing positional screws. Just they don't lag it, but just they put positional screw to anatomically reduce it. But that is also not necessary. You just bypass the fracture zone.
So that is the cautionary tale with this reconstruction by you putting in this case on. Although having said that, this is at 6 months. He's got full flexion, full extension, good SLR, and that's his same.
What about the final X-ray?
So this is the X-ray we have had at 5 months. This is 1 month back, but because of the lockdown, we've not been able to get another X-ray or a follow-up. So this is at 5 months. This is end July X-ray. So we are hoping to bring him back.
One test is if he has full weight bearing and no pain, then it still may unite.
That is what we are waiting, and I'm hoping the lockdown kind of gives us that time.
Yeah, if he has no pain, no tenderness, then you can wait as long as possible. The moment he starts paining,
That means it is a pakka non-union.
Yeah. Any role for a PRP at this point, sir? No, not with the gap.
No, there is no evidence. There is no strong evidence for that. There is no strong evidence.
Yeah, Ashish, you wanted to say something, yeah.
So basically, it's the mechanobiology at this place. And the biology we say is okay, but probably the mechanics is the one which is causing trouble in this one. So, I mean, just for the benefit of the viewers, there is and mixing of these principles. In the last case also you said that you can put cortical or locking screws in one particular fragment. So a word of caution is that if you have to put the cortical screws, you have to put the cortical screws first.
Yeah.
And if you can put all the cortical screws as well. I mean, use the same plate in with the principle of friction at the plate and the bone interface. But then what I would want everyone to do is that there is an article by an investigator called Pankaj. He's a biomechanist of Indian origin, and incidentally he was to come to Bombay for the WIROC meeting. There are two articles, and it talks about mixing of the principles, which is what you have attempted to do, like use a lag screw along with the locking plate. So it is possible to do that, but there are certain rules that we need to follow. So a very good article, but very complex one. It is about 8-10 pages, but takes a while to read that.
So this is actually from one of my colleagues. I just wanted to put in to get that cautionary tale across. And what I went about mixing the screws was that don't go in for all locking screws in the proximal. That is an independent factor of non-union. So that's essentially my piece. Thank you very much.
Good, very good.
Thank you so much for excellent pieces. Now we move further for the host chapter. I think it's time with Dr. GSK sir to present his
okay. Shall I put on the screen?
Yes, sir.
Please, sir.
Have you received my
Yes, sir. We can see your
case presentation. Yeah.
Yes, sir.
Now, this is an 18-year-old boy had a fall from motorcycle in January 2011. Open fracture of the distal femur. There was a circumferential wound, more on the posterior aspect, admitted within 12 hours of injury. 3 large pieces of bone were fallen from the femur on the road, which the relations picked up and brought. They were covered with mud. He also had Montague right side fractured tibia and heel pad avulsion. Now this is how he came. You can notice that there is an intra-articular crack here in the distal femur, and there is also a pieces there. So this is an intra-articular extension, but not displaced intra-articular. These were the pieces that they brought together, 3 or 4 pieces. And he had tibia and Montague, which were treated, and they got right. Now this is the large view, which shows the intra-articular. The arrow shows the intra-articular here, and this is the one. Now, how will you manage this case? Yes?
Anyone want to comment?
Anybody wants to comment? And
Dr. Rajeev
First of all, Dr. Rajeev.
Yes?
Can you show the X-ray again?
X-ray, yeah. This is the first X-ray, and this is the pieces, and this is the second X-ray.
Second X-ray. So, I mean, if you, he's a young lad, he has no neurovascular damage, but there would be a lot of soft tissue damage there.
Yeah, but so there's no neurovascular damage, yes.
Yeah, there is no neurovascular. So definitely salvage is the option for him. And initially I would put him for damage control principles. I would put him in an external fixator, spread the wound completely. And one thought is that because he's got such a big gap, we can either put some local antibiotic delivery options for the first 24 to 48 hours in case we are going to wait for him to stabilize, either with the help of cement beads or with the help of stimulant. Now the question of those two retrieved bone fragments is what has been published from China again. If you trust the Chinese literature, is that what they have done is with these bone fragments, they sterilize it and they place it in either the contralateral rectus femoris or the iliacus, and they just leave it in place as a auto banking of the bone. And what they have found that over a period of few months, the fragments actually develop vascularity, which they can be harvested and later on be used in this particular place.
Yeah.
So that bone will be used, and so that will be my initial plan in the first night when the patient presents to us.
Yeah, he came within 12 hours. He came at night, and we took him for surgery in the next morning.
Yeah.
And I will go ahead. What we did. See, the pieces were very big pieces. So pieces of bones were cleaned with brush and autoclaved. They were assembled with a wire and inserted in the gap, fixed with LCP and bone grafting from the iliac crest. Now the current is not to current tendency is, if you want to do this type of implantation, you soak it in 2% chlorhexidine for 20 minutes. That's one more approach for instead of sterilization, you can use this approach after cleansing. This is the piece. Then we assemble this into the exactly what it was. And this is the piece that was done. And this is the final piece which was inserted. There is an interesting case from UK. There is an interesting case from UK. There was a case like similar to this, and the relatives could not find the pieces. So they sent the dog, police dog, and the dog picked up the pieces and brought it without eating. That's it. And they fixed it. That was the interesting case published in JBJS. So this is how we fixed the plate fixed the fragments, and then temporarily passed the ender's nail. And this was done in 2011. So we fixed it with a plate like this. And the part of it is bone grafted here and here like that. And then, see, at 3.5 months, this was the picture. It started showing callus here and here. This is at 8 months, showing good callus, good formation of bone. This is at 1 year, the fracture is united, and the patient is up and on. He has not come after that, but on phone he asked me, I am all right, sir, I need not come. I am doing all works and all that. This was the answer. Again, last week I phoned him. He said, I am all right, I am okay. So this is his function at 1 year. And then this is the incision that we took. In India, there are 3 cases reported. 2 from Ganga Hospital, and all the 3 cases together we published in injury journal. Deen Dayal and Sunil, they published this paper. Okay. The second case we did in the second case similar way, but this was the medial condyle. But then it failed because of this severe infection. And there are literature shows about 12 cases or so. like this. Why you should do in only femur, but not in the tibia? Tibia, the failure rate is very high because there is no muscular envelope around it. The tibia, it doesn't work very well. And in the femur also, it is better to do in young people. That this boy was 18-year-old, so we took a chance. And what is important is you must very, very carefully monitor regarding infection. Infection is the main problem. That is because these are dead bones and biofilm immediately occurs on the dead tissues. So that is the only problem. So this was an interesting case. I have presented this once, but I thought it is better to present this to this also. Any comments, any questions on this?
So may I? With
Yeah,
due respect.
please.
So very interesting case, sir. And I would like to share a similar experience that I had.
Yeah, very good.
The difference was that the patient did not bring the bone back to me. So he came with a gap of that much segment missing. And so we did a debrema for the intra-articular fracture of the distal femur. We fixed it with the 2 screws. And on top of it, then we did a orthofix fixator at the primary stage. And as soon as the wound healed, it was a large wound on the anterior aspect, nearly 3/4 of the circumference. So posterior part was slightly intact. And then we did a debrema. And fortunately, the wound healed primarily. And orthofix, we did a primary corticotomy at the proximal end and started moving it. And over a period of about 8 months, it has united. In fact,
you have done bone transport.
Yes,
bone
I've
transport.
done bone transport. Yes. In fact, this patient also had a 4-segment fracture of the tibia in the same limb, for which we did a Ilizarov. Both were open. So he got a flap done down there. And initially it was treated with the external fixator, and later on we converted it into a Ilizarov just to hold the fracture fragments into place. And we were able to get him ambulatory also. But just my thought processes are that when we are doing with these dry pieces from the road, there is a very high, I would feel, tendency for infection.
Yeah, absolutely.
I would feel that the Ilizarov and the orthofix would be a far safer option. And probably with the kind of results that we tend to get with Ilizarovs and orthofix nowadays, it's pretty well documented that we would be getting a decent result. It's very rare that if it does not unite, we could always graft it at the end.
Yeah, I'll have my comments. We have a large experience with large caps. There are three ways of doing a gap treatment. One is to do a bone transport, as you said. But the problem of bone transport in femur is the knee becomes very stiff. That is the big problem.
Yes, that is true.
Because, the knee becomes very stiff. So in tibia, it is very good. In tibia, the bone transport is the ideal treatment to treat the gap. The second method is doing a muscular technique.
Yes.
You debride it, put a bone cement spacer, wait for 4 to 6 weeks, remove the spacer and do bone grafting. This works very well in femur, but not in tibia. The tibia has a problem. There are many problems. There are papers from UK saying that it should not be done in tibia, but it works very well in femur. So bone transport is very good in tibia, not so good in femur. Muscular technique is very good in femur, not in tibia. And the third one is that bone grafting, either a fibular graft or a cancellous bone graft. And Ganga Hospital have published a large series of fibular graft and a cancellous bone graft in the femur with good results. So these are the three ways of treating the gap in the in the bone.
Yes.
Okay. Okay. We can move to.
Sumit want to comment, sir. Yes,
Yeah.
Sumit. Click. Unmute yourself first.
Yeah. Okay. Yeah. Unmute.
Sumit, unmute.
Yeah. Yeah. So this was an amazing result which you got, but as you've also pointed out, Dr. Jayant also pointed out, that the uncertainty of that infectious thing is probably a big deterrent to it. I've done, when I was back in the UK, we had done that muscular technique wherein you put in the cement spacer and then use the vascularized fibula alongside the
Stop sharing, Rajesh.
vascularized fibula alongside the cancellous graft. So those are, I think, a bit more safer options in terms of avoiding the risk of infection. And yeah, all three methods can work. This one, if it works wonderful, the first method. But if it does not, then yeah, that risk of infection is too high for it to be a predictable or reproducible sort of a procedure.
Yeah.
Thank you. Sir, you want to present another case?
No, it's all right. I think we'll go for the next case.
So next, I would like to invite who's there. Because he's not there.
If time permits, I will go for the next case.
Yeah, next would be, I think, Dr. Pankaj Ahire.
Pankaj, okay.
Anta sir is not presenting case.
Yeah, sir has got some emergency issues, so he will not be able to join us.
We can go ahead with the next, sir.
Dr. Pankaj.
Yeah, thank you very much. I've been patiently listening to a lot of femurs and tibias. Now, in return, all of you have to listen to the middle phalanx and the proximal phalanx. And no,
that's more important.
No coffee break, no lunch break allowed for everyone. So let me just share my screen. Yeah. I'm just going to present a group of proximal PIP joint fracture dislocations, of which the dorsal dislocations being more common. Just of 4 representative cases and 4 representative treatment options. So this is one of the commonest presentations that you would see, and this was a young boy presented 2 weeks, and as you all of you would agree, most of them do present little late because they're playing cricket, and it's a sprained finger is a medal. They carry on with it, and when it despite 2 weeks pass, 2-3 weeks pass, it doesn't move. That's when the panic sets in, and this boy came like this. I was a little intrigued by this fragment, though there was no distinct fracture in the dorsal lip, I still believed from the location of this fragment that this could be a extensor tendon avulsion. At 2 weeks, the storm has settled. So really, the extent of the velocity of injury is not very evident by 2 weeks, 3 weeks. Most of the edema has settled down. So this is what I did for this patient. And so this was a volar approach and stable fixation of the volar lip. These are as many screws are required. Sometimes I put 4, 5, 3, whatever. 3 is the minimum. Interestingly, once I did this fixation and it was very stable, then my plan was actually then to go dorsal and fix the extensor tendon using an anchor. So when I opened, I found that was actually an intra-articular piece from here. And I simply excised it. The reason I was confident about it, just throwing it away, is it is known that in PIP joint fracture dislocations, once you have created a good volar restraint and the joint is congruous, even if there is a reduction of the articular anteroposterior length, or even if there is an articular step, the end results are equally good. Okay, so and then this boy went on to have excellent result. This is his range of movement. And they typically keep improving for about 6 months. For 6 months after the injury, they have a very steady improvement. It's not uncommon to have a bit of residual flexion deformity, which can be stretched out, but almost never requires a surgical release. This was another, yes.
What about volar plate? Was there a volar plate was
yeah, so the volar plate in this particular patient, the volar plate is attached to this fragment. So whenever I'm looking at fixation, I would not detach the volar plate from this fragment. I would detach the volar plate from this fragment only if I am thinking of doing a salvage procedure and not a reconstruction.
Good.
So by attaching this fragment, you have actually restored the volar restraint, which includes the volar plate as well.
Yeah.
So that the volar plate is practically fixed with this. So this is another case, almost similar looking fracture, but for that intra-articular piece. This piece in the last case was lying somewhere here. This was relatively fresh, very high demand individual, came within a week's time perhaps. So I decided to do just like we would approach any intra-articular fracture, did a volar open reduction, reduce the intra-articular depression, fill that gap using cancellous bone graft, which is harvested from the dorsal of the distal radius, dorsum of the distal radius, and then again fixation using 3 screws. These are again 1 millimeter screws. Important thing is to get a perfect articular reduction. Yes, if you get articular cartilage complete alignment, that's a bonus. But you cannot leave the joint subluxated. That's the key. And with a very stable fixation, you can do very early mobilization. This is as early as 2 weeks you can start mobilizing. So that's one big advantage of doing a good open reduction and a stable fixation. Occasionally you will have a shattered palmar lip like this, but as long as I see about 50% of more of the articular dorsal part intact, I just need to create a volar restraint. As I said, the joint needs to be reduced. The articular cartilage can have gaps and can have steps. So this is exactly what was done. Good articular reduction, a pull-out suture, because I attempted screw fixation, but I could not because this was too shattered. So I just put the soft tissues together. You have to believe that you will do a reconstruction and not detach the volar plate from these fragments. That is a key when you are approaching these fragments. And that's the end. And once you have a congruous joint, then you can keep working on it. As I said, for 6 months, they will keep improving. Occasionally, not occasionally, in fact, quite commonly, you will see a fracture like this, where there's only a dorsal lip, 1/3 of it, and 2/3 of it is gone.
In the previous case,
yes.
Do you think this will have some osteoarthritis or in future?
Osteoarthritis is not common in these joints because these are not weight-bearing joints.
Yeah.
However, if there is a hinged movement, if the articular reduction is not good, and if there's a hinged movement, then yes, that osteoarthritis will develop and it will become painful. With a congruous joint, even if the osteoarthritis develops because of articular steps, then it doesn't become very painful.
Yeah. Okay.
Dr. Pankaj, I have a question.
Yes.
In the previous case, to maintain the congruent or just pull it out, especially in more comminuted practice, do you utilize the dynamic distraction?
Dynamic distraction like a Suzuki frame is an excellent option. Yeah, excellent option. I personally do not use it. I have never used it, but it's a very good option. The key element is reducing the joint and maintaining the joint reduced through an active range of movement. If you are able to achieve that using a Suzuki frame or by open reduction, it is still fine. The key thing that remains is perhaps in any of these fixation where you have not done a complete articular reduction and open reduction and a stable fixation, then perhaps maintaining the joint reduced with 30 degrees of flexion is the key, because that allows the volar soft tissues to heal very well. The whole problem in dorsal dislocations of the PIP joint is loss of the volar restraint, as would be evident here. So there's complete loss of volar restraint here, and this joint, even if you do close reduction, it is not going to remain reduced. And as I said, it's very common for these patients to present very late. So this patient also presented very late, and this is what happens. This is a non-salvageable situation. And whenever you have a non-salvageable situation like this, very late presentation, a hinged movement, yeah, it's very difficult to do an articular reduction in this time. And then this is what was done for this patient. Some kind of, you can see the gap still exists. The joint is slightly better reduced, but there's still some residual subluxation once this stabilizing wire or the extension block wire was removed. So I'll just explain what was done for this patient. You have two options for such patients. One is a volar plate arthroplasty, and another is a hemiamate osteochondral autograft. Both these are essentially again restoring the volar restraint. That is what is important. So this is how the volar plate arthroplasty works. So if you just remember this X-ray picture and then you see this line diagram, X-ray picture and line diagram. So if you see this line diagram, so that is where your volar plate is with the articular fragments attached to it and the dorsal dislocation. Now, when you have a severe comminution in this area, you know, you would want this to reduce here, but with severe comminution and a neglected fracture, this will not be possible. So this goes away. You need to excise these small bony pieces. Now you are left with a bony defect. The joint is reduced, can be held with either a wire or you can hold it using an extension block wire. And then this volar plate is now inserted into that defect and a pull-out suture is inserted. This is called a volar plate arthroplasty. This is good if there is less than 50% bone. This is exactly what was done for this patient. That is a button that you see. There is some residual subluxation, but once the volar restraint is restored, this is the movement that you get. Is the index finger on the right side that is operated. That's the result that you get from a very stiff finger. Occasionally, you have something like this. I attempted to reduce it and see what happens. Even if I wanted to use a fixator for definitive reduction, I would not use it. This was 5 months post injury. The articular fragment simply goes away. Now there is no way of filling this gap. And when the defect is more than 50%, see this is a more than 50% articular loss. Then volar plate arthroplasty is not an option. So what was done is I carve out this defect and make a very regular defect, a rectangular defect, and fill that defect using a bone graft, an osteochondral bone graft taken from the hamate. Now this piece is taken from the hamate and fixed using 3 screws. Once you do that, then this is what you get. So this is what you get.
You can do hamate in this case?
Yeah,
hamate
this is the hemihamate. This is the hemihamate. That is the hemihamate graft. You reduce it. And this is the intraoperative. This is done wide awake. So there's only a local anesthetic that is used. So this is on table, he gets more than 100 degrees of flexion.
Fantastic.
And this is about, I think a few months down the line. And this was operated more than 8 years ago, and he's doing pretty well at the moment. So when you have a stable fracture pattern, the close reduction may work. But when you have an unstable fracture pattern, you need to go for a proper fixation as you would do for any other intra-articular fracture anywhere else in the body. And when these are neglected, the focus has to be on restoring the volar restraint, which can be done either by a volar plate arthroplasty or a hemihamate arthroplasty. If you have any questions, I'm happy to take. I'll just leave the presentation on, just in case I need to go back.
Any questions from anyone?
Good, very good presentation. Nice idea.
What tends to be a rehab protocol, Dr. Victor?
Yeah. So if I'm dealing with a fresh fracture and I have got a good intra-articular reduction and stable fixation, I would mobilize them immediately. When I say mobilize immediately, I still don't allow them to do forceful extension. They are allowed to do flexion as much as they want, relax, but not active extension for about first 3 weeks. After 3 weeks, after
Do
3
you
weeks,
give a sort of an extension block splint?
no, I would not give if I have done a good open reduction and fixation. I would allow them an active extension at about 3 weeks, and after 6 weeks, I would even allow them to use their other hand to gain some passive extension. If I have done a volar plate arthroplasty or a hemihamate or any other method of indirect reduction where the fracture has not been directly fixed, then I would use extension block at 30 degrees. There are various ways of using the extension block. I could use an external splint, I could use a wire, I could use a plaster. There the dictum is you maintain 30 degree of flexion attitude of the finger and allow full further flexion. If you are not able to do this, if you require more flexion or if you are not able to allow more complete passive flexion, then you need to intervene. Then it requires intervention in order to achieve joint stability such that from 30 degree flexion, a further active flexion is allowed. So in that case, I would use splint, plaster or a wire. Wire is the least preferred one because wire tends to go through the substance of the extensor apparatus. So I'm happy with a plaster or an external aluminum splint. There is a very nice way of applying a external aluminum splint. If time permits, I will show it.
Any other questions? So good series of cases, Dr. Pankaj. Very nice presentation.
Thank you very much.
Now I would like to invite Dr. Ashish to present his cases. Dr. Ashish.
Yeah. Can you see the presentation?
Yeah.
Yeah. Thank you very much to the Rajasthan Orthopaedic Association, the Maharashtra Orthopaedic Association, and the IOA, along with Dr. Swapnil Keny and Dr. Sandeep Biraris for having given this platform.
Ajit,
and
sir,
a very interesting morning we spent together.
Can you just play it, sir? Play.
Ek minute, I can't see that play option. One second.
It's
Perfect.
Yeah. No, this was coming in between. Ek minute. Right. So thank you very much, Sandeep. Thanks, Dr. Swapnil, and regards to everyone. A very good morning spent, and I think we are in the last leg of our program. So I had a few cases to show about the distal tibia intra-articular fractures, but in the interest of the time, I would just show one case which has taught me a lot of things and a really very humbling experience when we have managed this particular patient. So he is a 68-year-old retired scientist, and he is from the BARC, which is very close to us. And he is sort of a nuclear physicist, a very astute person, and he's a very keen chess enthusiast. So he's also a chess teacher. So on one of the days when he was going to his academy where he teaches chess, he fell from a bus which was slowing down. It had not even slowed down. He fell from that, and unfortunately, he was sort of the shearing injury to the lower end of the tibia by the tire which was following. So he presented to us within the first 20 to 30 minutes following the accident, and this is how the wound looked like. So this is the picture. So you can see that there is a almost circumferential skin loss and a soft tissue loss. There is a gross contamination of all the tissues over there. It's virtually like a mangled extremity. He's a 68-year-old. He's diabetic. His sugars are very well under control because he looks after his sugars well. The dorsalis pedis we could see from the wound that was contused and lacerated, and in the zone of injury, it was damaged to quite a large extent. The posterior tibial, however, was seen through the wound and it was pulsating very nicely. So he had a good sensate vascular limb, And these were the kind of x-rays that he had presented to us with. So you can see that it is a completely disrupted ankle. There is an intra-articular fracture. Probably you can classify this as a partial intra-articular, but a lot of soft tissue skin loss. We decided to classify this and try to see whether this will be salvage or whether we need to go ahead and do some non-salvage procedure like an amputation. So we decided to do a Ganga Hospital injury severity score, and it came as 16, which is borderline. So we talked to the patient, and the patient in no uncertain terms said that he would like to give it a shot at the limb salvage if possible. Now, the challenges in front of us were how to proceed, and I'll just show you what we have done so that we can come back to it later on. So in the initial stage, immediately we took him for an emergency debridement. We used an external fixator. It was thoroughly debrided, and we irrigated with a lot of saline. We took out all the dead necrotic tissue, all the tendons, and not the tendons, but the soft tissues which were contaminated were taken out, and we applied sort of a sterile dressing. Initially, for the first 12 hours, we had kept him in the ICU for his sugars and everything to settle down, but the general condition was good. He was otherwise in good health, and this was the wound which was there at 24 hours. So after having a discussion with the plastic surgeon and with the sort of a multidisciplinary team, we thought that this wound looked good and we should opt for an early cover. Now, we were quite interested in doing an early fixation and a flap cover. The choice of the flap here was, there was no choice of a local rotation flap. So it was a free flap. The problem was he had only one donor artery, which was a posterior tibial. So what we decided to do, or the plastic surgeon decided to do, was he decided to do a latissimus dorsi flap. And the pedicle, he sort of anastomosed to the dorsalis pedis, but much higher than the zone of injury. So he had to take out a very large soft tissue graft, and he covered the entire defect. However, at the same time, we proceeded with our internal fixation. So this is what we had done. We had done some internal fixation using the pre-contoured locking plates, using a lot of K-wires, a few lag screws, fixing the fibula and trying to get it to the optimum length. So the sequence of fixation, though it was the fibula first, we then fixed the syndesmosis, but at the same time also having a look at the medial side. So this is what the fixation looked like, and we handed him over to the plastic surgeons who did a flap at the same sitting. So this is the first 24 to 48 hours. Fortunately, the course in the ward was uneventful. You can see the stimulant beads which had almost 1 gram of vancomycin and 1 vial of gentamicin for a local antibiotic delivery to prevent an infection. Over a period of time, the wound healed, the skin graft and the flap also took very well. He did not have any discharging sinuses. There was nothing to suggest any kind of infection. So over a period of time, even the flap healed, the soft tissue healed. We had maintained him in a fixator just so that the soft tissues could be taken, very well care of. This was the X-ray at about 2 months. So still we thought, there's nothing very alarming, and the patient was grateful to have a sensate limb. He was mobilized with the help of a walker. Obviously, he was non-weight bearing, but then he had been through a lot of, hospital admission. You can imagine the kind of injury, blood transfusions, ICU stay.
Shall I comment?
Yes, sir.
Go back. Yeah, this. Go back one. Yeah, same. Say, go back. X-rays. This has a syndesmotic injury. This is because the fibula was widely displaced. Yeah. So syndesmotic injury, you have put a screw, one screw, which is obliquely placed, and also very near the articular cartilage. So it should be at least 2 centimeters above and reaching to the medial cortex, up to the medial cortex. And you can put one more also, because this was a very widely displaced. So going from plate, fibula, and another syndesmotic screw would be more stable also. It adds to the stability. So this is only one comment. Otherwise, very nicely managed the case.
Yeah.
Very nicely managed.
it was quite a fiddle to fix these fracture because everything was so wobbly that we couldn't get a hold on a lot of things, and it was also dictated by the sort of bone loss we were facing. So we were quite happy that there was no infection. We were quite happy that the patient had no pain. He had started toe touch weight bearing. This is the X-ray at 6 months where we could see that the fracture is sort of drifting into a bit of a valgus at the diaphyseal site. The lag screws which we had put initially with good intent now started becoming a bit of an eyesore. And there was some concern here at the medial malleolus where we have seen the implant failing. So at this moment, we thought that, the implant is failing. He's heading towards a non-Indian, and we decided to offer him a second surgery with a lot of telling him that it would be a very extensive surgery to intervene, that we would have to lift up the flap. We would have to probably consider a bone grafting, maybe an arthrodesis of the ankle if we have to have at least a decent hold. But this patient, fortunately for me, is a very understanding patient, and he did not desire any further surgery. Sorry. This was his skin condition, sort of an exuberant granulation tissue which had healed without any any discharging sinuses or so. Though the skin condition, it could look a bit more cosmetic. This is how it was looking. He continued to carry on with it for about 12 months or so. He was walking on it now full weight bearing. So I was hoping that, it will form a stiff fibrous healing, or maybe he would form some callus. And then, I don't know if you can see these oblique X-rays. The oblique X-rays show evidence of implant failure and frank signs of non-union at the diaphyseal and the sort of a metaphyseal-diaphyseal side. So he continues to not opt for surgery. He is not having any pain. He's able to do whatever he wants, that he teaches chess and lead a retired life. But yes, though, he's not complaining. I would not count this as a very successful outcome. But
if he has no pain,
yeah.
if there is no pain, you should not interfere anything till he gets pain. Pain is a very, very interesting phenomena. If your X-ray shows non-union, but the patient has no pain, you have to wait. Only one concern that you should inform the patient, that there is one rare possibility of breakage of the implant.
Yeah.
That's the only one you should take.
So this has broken. There are a lot of screws which you can see that there are broken on the fibular plate as well as the medial side, the distal fragment. There are screws that are broken. So this has been shown to him, but he still is very happy to. Happy is sort of assumed and accepted how his leg is, and he said, as long as I have a sensate limb to do the meager activities that I am doing at home, he is okay.
Was he full weight bearing?
Yes, he is at the moment full weight bearing on this particular thing. But you can imagine that his mobility is very restricted. He just walks inside the house, and he takes his he's driven to his chess institute where he teaches chess. He doesn't go to the market, or he doesn't have to walk for a daily activities. He just has to wait at home and sit down and play chess.
Very good.
So fortunately for me, there is a relatively low demand, or really a low demand for this type of a fracture. But this was a very humbling experience for us to keep on treating him and talking to him all the while when the patient is very cooperative and the injury is working against us.
Yeah. Now, can I add to this?
Yeah.
One thing, the plate should be again a longer plate. Plate. The longer the plate, more stable is the construct.
Right.
Secondly, there is now a concept of what is called a profibular tibia fixation. That means you fix 2 or 3 screws passing from fibula into the tibia. Here, the fibula and the plate acts as a dual plating. Similar to, you have done dual plating, but there should be fixation from fibula to tibia.
Yeah.
Just like a syndesmotic screw.
Yeah.
Put 1 or 2 screws down and one or two screws above. And that gives you a better fixation, stable fixation. This is very well done, no doubt about it.
What is it called, sir?
Pardon?
What is it called, the procedure using these two plates across each other?
Two screws, you mean profibula,
Profibula.
screws? It adds to the stability.
Okay.
Because the fibula also acts as a plate to the tibia.
Yeah.
Fibula acts as a plate to the tibia, and it's a dual implant which gives you a very stable fixation. And in such cases, it may not go into non-union.
Right.
Yeah. This is one.
Anyone else want to comment regarding the fixation, or may try different kind of fixation in this case?
I think Ashish, again, that Kulkarni sir already said, a slightly longer plate, and also that those interfract screws now in a hindsight look like probably it would have been a better off option not putting them on. So, but yeah, I mean, the fracture essentially is at that watershed area as well, where the circulation probably to the tibia is probably the worst. And with all those soft tissue injuries, there wasn't really much left to begin with. So, yeah, well, lucky for you, that patient is so cooperative.
Sumit want to say it was act of God.
Every fracture healing is an act of God.
Okay. Next case. Dr. Ashish.
I think we are. Have we run out of time, or?
No, you can just go ahead if you have one more case. This is the last case you have?
This is the last case, yeah.
Sure, please go ahead.
No, I think this was the most interesting. I mean, other cases are all okay. I mean, just
after this, I will show you quickly one more case.
So you can show your case, sir.
No, you can show. You can show. First show. Chalo?
Yeah.
We have still about 20 minutes or so.
Okay. So basically, there are one or two good articles which have come in with the management of distal tibia fracture, and as we know that these the geometry of these particular fractures depend on the position of the foot at the time of impact. So what I wanted to highlight in the next couple of slides was, this is a particular laborer who had fallen from the first floor, and as you can see that there is a lot of comminution anteriorly. There's a big posterolateral fragment, and there is a medial malleolus which is a big chunk. So in him, we have done a dual plating. We have fixed the fibula through a big extensile anterolateral approach. To the same approach, we went on reflecting the soft tissues, and we used an anterolateral plate and made a separate incision and fixed the medial malleolus also. Now, and this is the sort of a first follow-up X-ray. So the fragments, everything is holding on well. The skin condition is also good because we have taken care to space out the particular incisions. But the importance of a dual plating is something that I would like to highlight, which was recently published by Dr. Sumit Banerjee. Now, this is the other type of a fracture where you can see that there is a comminution centrally, posteriorly, and again you can see that the medial malleolus is a big fragment with a sort of a marginal impaction at the medial end of the where the talus at the medial end of the morta is. So in this lady, we have used a medial plate, also supplemented the fixation anteroposteriorly to hold the anteroposterior fragments, and then also restored the length of the fibula.
This is an ideal plate, very ideal plate. You have put only three screws, long plate. Yeah. This is a very good ideal fixation.
Ashish, the one comment with that one would be, you could go from the posterior lateral to fix the fibula, and that way that posterior malleolus screws would have been a lot better, rather than anterior posterior would have gotten the bigger fragment. The middle side is fixed extremely well, no doubt.
Yeah. So this is the fragment in which the patient's leg probably was in equinus when she fell, and hence you have a big posterolateral, posterior malleolus, a posterolateral sort of comminution and a fracture, which we have used using a posterior buttress plate and a screw, as Dr. Sumit mentioned, going from back to front. The interesting study is this one. Dr. Sumit Banerjee et al. In the Journal of Orthopaedic Trauma, they have made what is called as a pylon map. So they have looked at some 50 to 60 sequential CT scans of AO type C fractures, and they have documented and drawn these fracture lines. What the essence of this particular paper is that the pylon predominantly is broken into 3 or 4 different fragments. There is a sort of an anterior fragment which is there in about more than 50% of the cases. 76% of the patients have comminution in the anterior fragment. The medial malleolus occupies is there in 84% of the number of patients and occupies almost 40% of the articular surface. And the posterior malleolus occupies the 26% of the articular surface. So it is a very large fragment, and it is always a constant fragment that is there in these particular type of fractures. In more than 50% of the patient, 20% of the articular surface was involved, and it was quite comminuted when it was involved. Now, as a corollary to this particular paper, there is another important take-home message is that the modern distal tibia plates which are there, can one plate be an answer to all these type of fractures? So the answer is no. So whether it is the AO, the Smith & Nephew, or whichever variants of Stryker or any other companies which have come, they say that there will be a tendency for all the anterolateral plates to miss the medial malleolus. There will be a tendency of the medial malleolus plates to not buttress the anterior comminution which will be there. And hence it is quite imperative that a lot of times you will require a dual plate fixation for a stable fixation of these particular fractures. So this, I think, in the last 5 to 6 years is one of the most important take-home messages which has come in management of these distal tibial intra-articular fractures. That's all I wanted to convey.
Very good.
Thank you.
This dual plating is a very interesting phenomenon. They're coming up in orthopedics in a big way.
Yeah.
Distal femur, proximal tibia, distal tibia, all these require dual plating, either 2 plates or a nail and a plate. This is all coming up very big way. Dual implants or so-called dual implants is coming in a big way. So shall I show you?
Yes, sir.
Shall I show one last case?
Yes.
Okay.
Sir, please.
Back झालं पाहिजे. First. नाही तू पुढे चाललास. हे पहिलं आहे का? This 40-year-old man had motorcycle accident. He sustained fracture of the distal end of the femur, open grade 2 fracture, and you can notice that this is a very severe injury. His lateral condyle, entire lateral condyle is seen outside and is migrated proximally. This is the patella that you see here. So this is the fragment like this. This was the fragment which has gone up like this. This is the lateral. And we did, because his foot pulsations were feeble, so arteriogram was done. That was normal in the first part, but I will show you this. This is the CT scan done. These are various fractures. Displaced lateral condyle, comminuted medial condyle, and this is the patella which is also fractured. He had compartment syndrome, so we had to do a release, and this is the clinical pictures of the scene on the. Let us go fast. So we did debridement and put beads and fixed these 2 screws, and then external fixator. External fixator was applied from above to below so that it should not come in the way of fixation. These are all the important questions that you should have when you plate distal femur. The fracture was reduced as in one of the cases. This was this was done long back. The plate is short and this working length is too short, and this is bound to have a non-union because there is a gap also here. So at 4 months, you can see the gap there here. So it went into non-union because of this. This screw is the most important screw, which should be somewhere here, and the plate should be above, and one screw at the end, and one screw in the middle. 3 screws are all that is required, or at the most 4. If the plate is too long, you can put 4 screws. So the most important is this screw should have been somewhere here, and then this should have united. Now this went into non-union, and there is a triangular gap here. So what we did was then pakka non-union, and note there is a triangular gap here like this. So what we did was to put a iliac crest graft from here. We didn't do anything here because now we are having a sort of a compression type of fixation. So we just put on the medial side, opened on the medial side, and put a big chunk of iliac crest graft, triangular thing, and the fracture united. He has this, and he has a good function. The same thing. Okay, thank you.
Thank you, sir.
Yeah.
Thank you for the nice case presentation. So now we come to the end of the session. So very fantastic cases and a good discussion on all the cases and all the master comments by Dr. Kulkarni sir.
No,
enlighten all of us with the words of wisdom.
No, yeah.
So at the last,
whole thing was very,
I would
very.
like to, on behalf of
I thank the Rajasthan group and
sir.
the Bombay group. Very nice presentation. We learned a lot. I also learned a lot from you, from these cases. And well done, very well done. Congratulations, all of you. Thank you.
Thank you.
Thank you very much, all the faculty, as well as the office bearers of the Rajasthan Orthopaedic Association. We had a fantastic session going on right from all the intra-articular fractures of the upper limb to that of the lower limb. Very, very comprehensive. And on behalf of the MOA, the BOS, and IOACON 2021, I thank all of you all for your contribution. And we hope to see you and other people and other delegates from your state attending our conference. Thank you very much and have a wonderful day ahead. Thank you.
Thank you.